We are live.
Yeah. Good evening, everyone, and thank you all for joining on the day two of Rewind 1 2026. With immense pleasure, I would like to invite Dr. Lokesh. And Dr. Lokesh is a medical oncologist at Kidwai Memorial Hospital, Bangalore. Over to you, sir, for the welcome and introductory note.
Yeah, good evening. Good evening, all. I again welcome for day two for Rewind 1 2026. All of you. So, day one was excellent yesterday with mainly involving the breast and lung cancer session. Now, today we'll move on to the GI and GU and some gynec session also in the beginning, followed by mainly the hematology sessions. So, it's all jam packed also today. And last talk is by related to artificial intelligence in medical oncology. So hope you are all waiting for the same. So let's begin with the first talk by Dr. L.K. Rajiv, Associate Professor, Medical Oncology at Kidwai Institute. So he will be talking on ASCO updates with respect to GI and GU cancer. So over to Dr. Rajiv.
Good evening, all. Just allow me to share this. It's echoing, Yes, good evening, all. Without wasting my time, I'll just go to my talk. I will be presenting four abstracts from the. Why it is echoing? Tech support. So I'll be talking on this EV302 study. This is the phase 3 study. I will be presenting 3.5-year follow-up data and response analysis. Going to the background, we know that EV302 and Keynote A39, we established that this is the new first line. Can I continue? I am getting echo. Tech support. Hello.
Sir, are you logged by two devices?
No. Only the laptop.
Tech support, kindly help. No, sir,
So we
you
know
are
that
logged in by
EV
two
plus
devices.
Pembro as a new first line standard, and the longer outcomes data important to establish whether the efficacy of the benefits are maintained and deep responses continue to show durability, and the safety profile is maintained. So the study design is, we know that it is a locally advanced or metastatic urothelial cancer which are randomized to EV plus Pembro with chemotherapy, and the primary endpoints are PFS by blinded control and OS and other secondary endpoint. And the stratification they have done was cisplatin eligible and PDL expression below 10 and above 10 and liver mets. So this is updated OS in the intent to treat population. At 3.5 years, the estimated 44% patients in the EV arm, you can see here, are alive compared to the 24.6%, almost 20% benefit. In the subsequent therapy, so the most common first subsequent therapy in the platinum based therapy was resulted in almost overall response of 21% with a median survival of nearly 11 months. You can make out here, they use cisplatin, carboplatin, both the thing. So the further in the intent to treat population, the most common first subsequent treatment with the PDL1 was, so you can make out here, so carboplastin based therapy or cisplatin based therapy. The other immunotherapy is also used in these therapies. So the objective response and the CR rate in the EV302, you can make out. So chemotherapy was versus EV plus Pembro. So there is a huge difference. the 67.5 versus 44.2%, almost 30.4% CR compared to just 14.5%. Among the patient confirmed with CR, 66.2% achieved PR initially. And then they converted into PR to CR. So the baseline characteristics nearly well matched. So the median time to CR. So you can make out here the median time to CR is the 4.3. This is this line. So some patient they went into the good number of patients from partial response to CR. That is 6.6%. The overall safety population received treatment for the median of 9.6 months. And you can see the PR, achieving PR is also 2.1 months. Coming to the cumulative response, you can see most of the patient they achieved CR over the period. And if you see in this bar diagram, the cumulative overall response, the green color shows the CR. The most patient they achieved CR, they are not progressed much. Among the patient with CR, the OS you can make out at it is 83.6 versus 68% compared to the uh, chemotherapy at 42 months. So even if the patient, those who are converted from CR to PR, they also had the equal benefit, 67 versus 82.4 months. So the patient remaining on treatment and dose modification, you can make out over a period as expected, there is a decrease in the patient population, those who taking. And coming to the safety, so as the time increases, the safety profile also compromises. So most of the patient take 12 cycles and over a period, they decrease, the population is decreased. Coming to the treatment related AE, so this is the EV related sensory neuropathy and screen reaction of the more. Even come to the Pembro, it is as expected hypothyroidism and other severe skin reaction and hypothyroidism, pneumonitis are the commonest things. To conclude this study, with the 3.5 years of median follow-up, EV plus Pembro continues to demonstrate superior OS benefit. And after EV, the platinum-based chemotherapy was the most common subsequent therapy. And the EV plus Pembro demonstrated overall response exceeding chemotherapy. And cumulative responses deepened over time and demonstrated consistent and manageable safety profile. So, enfortumab vedotin plus pembro is associated with durable clinical meaningful outcomes in the metastatic urothelial cancer. I will go to the next study, and this is a Proteus phase 3 study. So here they wanted to look for the apalutamide plus ADT as a neoadjuvant or adjuvant. So background is what we know in a high risk locally advanced prostate cancer, despite radical prostatectomy, curative intent of therapy in patient with high risk is not there. More than half of the patient will relapse. So to improve the outcome with this, they wanted to see apoptotic effectiveness in this metastatic CSPC or non-metastatic CRPC. So this is the Proteus, a randomized double-blind placebo-controlled phase 3 study. They randomized initially neoadjuvant. So they have given apalutamide plus ADT. Then radical prostatectomy is done. The ADT is also done here. Then continued for initially neoadjuvant 6 cycles, followed by 12 cycles of adjuvant therapy. And one good thing here, they used PSMA PET at every 3 months. So the endpoints are hierarchical testing. They wanted to see is the pathological complete response and the MRD and metastatic free survival and other secondary endpoint. So the statistical analysis, I will skip this. So fairly well matched study. So at the end point, you can see the overall response. You can see adjuvant or neoadjuvant, you can make out hardly 0.4% T0, but 5.1% T0 with 8.9% versus 1%. This is almost ninefold improvement in pathological CR or MRD of following 6 cycles of a neoadjuvant apalutamide. So, in the metastatic free survival, also you can make out almost 20% reduction in the risk of metastasis. Coming to the event free survival, almost 29% reduction in the treatment duration. The patient going for the next line of treatment, time to first subsequent therapy are nearly 3 months treatment free survival in the neoadjuvant or adjuvant arm. In the first subsequent therapy, you can make out here most of the placebo they went into systemic therapy. The numbers also less with the apalutamide arm. Time to distance metastasis, again there is a 32% reduced risk of distance metastasis. Coming to the metastatic free survival, again you can 383, almost 84, 87, 4%. And one good thing here is they use PSMA PETs. So, and another thing is here the testosterone recovery also. So, median value was to 270 and compared with the 290 with the placebo arm, and median time to is 6.6 months. So, the frequency of treatment related adverse event, again, as expected, the apalutamide arm was more, but they are all manageable. So the interest of special interest of A is you can see IHD and non-pathological fracture and cerebrovascular disease. These are all comparable. So the conclusion. So the Proteus sets a new standard of care for high-risk locally advanced prostatic cancer. So it is the largest size study, and it has a novel endpoint. It has a PSA conclusion. So enhanced disease control, it is a significant 9 times better pathological complete response, 20% less risk of metastatic free service, 29% less risk of recurrence of death, and 3 year longer time to next treatment. And safety, it is manageable. So I'll go to the next study. This is one more study. So they wanted to see the effective of talazoparib along with the enzalutamide in a metastatic castrate-sensitive prostate cancer which harboring homologous HRR gene alterations. So, what is the background? This phase 3 TALAPRO adding talazoparib with the enzalutamide is significantly prolonged the radiological PFS and OFS in metastatic CRPSC. They wanted to see that these benefit within HRR gene altered metastatic CRPC. So trial design, it is a TALPROS 3 study. They stratified according to the de novo versus relapsed metastatic CSPC, high versus low burden, BRCA mutated versus non-BRCA mutated. They used talazoparib with enzalutamide. So the primary endpoint was radiological PFS and other parameters also. So statistical consideration, again, it is a hierarchical testing. It is also baseline well-matched characteristics. The primary endpoint by the investigator assessed PFS, you can see the benefit, the median follow-up of 37.6 months. So the hazard ratio of 0.48. So you can see 56 versus 76, almost 20% benefit in the PFS. In the subgroups, BRCA mutated versus non-BRCA mutated, the benefit was also maintained. That is 63% reduction in the BRCA mutated and 43% in the non-BRCA mutated. And the subgroup analysis, most of the parameter subgroups has the benefit. And if the gene analysis also, the recurrent-free survival is generally favored the most of the gene subgroup, HRR gene subgroups, except for this FANCA. Maybe this is because the numbers were small. Coming to the overall survival, this is an interim analysis. Almost 8% benefit was seen here. So the subsequent systemic antineoplastic therapy, again, the Telezo arm was less. The 55 patients in the Telezo and 113 patients in the control arm progressive disease. So time to TSA progression, again, it is favoring Telezo arm. Almost 49% benefit was seen with here. Time to subsequent systemic antineoplastic therapy, again, it favored the Telezo arm. Tumor response, again 42 versus 71%. So again, here the median duration was not reached, and this CR were also highest in the Telezo arm. Coming to the safety, as expected, but the discontinuation was more with the Telezo arm compared to the enzalutamide arm. The most common AE we see with the Telezo was anemia, and grade 3 is also more with that. So anemia with the Telezo arm, it has seen in the initial period. So over the period, it comes down. The patient-reported outcome also, there is no clinically meaningful differences. To conclude this, Telezo plus enzalutamide has clinically meaningful and statistically significant prolonged PFS. And OS tend to favor the Telezo arm, and time to PSA progression and time to subsequent anti-neoplastic therapy again favors the Telezo arm. So I'll go to the last study. This, they wanted to see durvalumab monotherapy in a resected primary renal cell carcinoma. So here the original sample size was more, but this was started with the COVID period, but it was compromised there. The steady outcome they wanted to see in a confirmed RCC with higher intermediate risk. The benefit of Durva or tremelimumab or Durva alone has a, what is the outcome? So this was the Livobovi score calculation. So we know that higher the calculation, poorer will be the outcome. So this study randomized into 3 arms. They used durvalumab plus tremelimumab, Durva alone, and active monitoring. So it is fairly well matched study. And the primary analysis, they kept a 80% power of the study. So in the intent to free, disease free survival, at the median follow-up of 3.5 years, the hazard ratio was favoring 0.74. That is 26% benefit with the Durva alone. And if you see the 3 years DFS compared to the active monitoring with the Durva, it is 72 versus 78%. But if you add tremelimumab, another 8% benefit, extra benefit was seen. So the DFS was higher and intermediate risk in the pre-specified and pre-powered analysis. The better was seen in the higher risk group. Coming to the subgroup analysis, again 3-year DFS, it is 76 with the this is DFS. Durva with the tremelimumab 76%, Durva alone is 66%, active monitoring was 61%. So again, this is a one-side p-value, the favoring the Durva, adding Durva or Durva tremelimumab. In the intermediate risk group, again, this is not a favorable. You can make out here, the p-value is not supporting adding durvalumab or durva with the tremelimumab. So in the exploratory analysis, they have seen the active versus the durva. So except the chromophobe, the other and WHO PS1, the other parameters supported, but these were not statistically significant. Coming to the overall survival, again, if you see the 3-year OS, the p-value was not significant. So treatment exposure, most of them, they received 11 months of infusion.
Last 2 minutes.
Coming to the last two slides, the safety summary, the safety, except for systemic corticosteroids used in 43% of patients, most of the AEs they are manageable, and even the tremelimumab has the more asthenia and fatigue. Coming to the all-cause high-grade adverse events, again, durva with tremi has the higher, that is diarrhea, colitis, and transaminitis were the other factor. The quality of life, and the quality of life, the change in overall quality of from the base, there is no statistically significant. So the key message, durva monotherapy following the resection in the RCC showed no statistically significant improvement in DFS, and durva plus tremelimumab significantly improved the DFS compared to the active monitoring, and safety findings are consistent. There is no evidence of difference in overall health quality of life. So I will end here. Any questions?
Thank you for a wonderful talk. So what according to you may be the practice changing for us?
So adding durva in RCC, resected RCC is a failure study. There is no benefit here.
Yeah, no benefit.
Only the benefit is it is a EV plus Pembro. Here, most of the patients are cisplatin ineligible. So, and it has a highest CR rates. This is one practice staging. Enfortumab with Pembro is a positive one. So maybe in future we can go without cisplatin. And here also adding apalutamide in the radical prostatectomy group. These patients will also benefit from adding neoadjuvant thing.
Apalutamide.
And apalutamide. And here telezo, adding telezo in a HRR group, they also have the benefit.
So all are positive studies except using adjuvant durva in RCC.
Durva in RCC is a.
Okay.
Talazoparib is in second line, Rajiv?
First line.
This study, it is a first line.
First line HRR.
The Talpro 2 they did in the second line.
But they have mentioned castration resistant prostate.
No, here is CSPC.
Castration sensitive, but
Talpro is a CRPC. So they wanted to see the benefit in CSPC.
Okay. So first line BRCA mutated, they have a benefit in this one.
Yes. HRR. The benefit is more in BRCA mutated also.
I mean, even non-BRCA also they have benefited.
No. HRR.
But
HRR
non-BRCA, HRR positive.
HRR positive. These are the Gs they tested.
Okay, fine. Thank you for a good interaction. So next we'll move on to the next session sponsored by BMS by Dr. Srinivas BJ, Senior Consultant Medical Oncologist from HCG Hospital, Bangalore. So he will be talking on optimizing HCC outcomes, leveraging key insights from Checkmate 9DW. So over to Dr. Srinivas.
Thank you, Dr. Lokesh.
Support team, please stop the recording.
Okay, yeah.
So shall I share my slides?
Yes, the role of dostarlimab, that is Jemperli, in endometrial cancer. So immune checkpoint inhibitors and chemotherapy rationale. So patient with advanced or recurrent endometrial cancer need additional treatment options, and it's a combination of immune checkpoint inhibition with chemotherapy may improve treatment response in certain patients. So why immune checkpoint inhibitors are useful in patient with DMMR or MSI high? It's due to increased mutations that promote anti-tumor immune cell reaction and also increased tumor infiltrating lymphocytes. So that is more likely to respond to anti-PD-L1 therapies. So that is the main reason. It's because of increased mutation promoting anti-tumor immune cell reaction and also increased tumor infiltrating lymphocytes. And again, chemotherapy, it's a cytotoxic, both combined together, known to cause a very good effective combination. So what are the biomarkers we need to test for patients with endometrial cancer? Again, all that biomarkers of what usually we do is the pole mutation, then IHC for DMMR or even PCR for MSI high, and then ERPR and also the P53. All these we do for all our patients with endometrial cancer to clearly find out the risk and decide the treatment options. So DMMR endometrial cancers can be associated with higher rate of recurrence versus intact MMR, and also higher rate of distant recurrences versus intact MMR. So a mutation that increases the risk of Lynch syndrome, that is MMR, an inherited condition that increases the risk of endometrial cancer also. So as I told already, the DMMR, it's by IHC, loss of more than or 1 MMR protein. PCR or NGS will detect MSI high. It's a DNA repeats which are unstable. So this MMR MSI testing is recommended for all patients with primary advanced or recurrent endometrial cancer. So I'll be discussing on RUBY Part 1 trial results. So this is a study in all comers with primary advanced or recurrent endometrial cancer, overall population, a long median follow-up of an immunotherapy combination. So all comers randomized, Jemperli 500 mg with Paclitaxel 3 weekly for 6 cycles, followed by Jemperli, it's every 6 weeks for up to 3 years, versus chemotherapy, Paclitaxel with placebo, then placebo for 3 years. So efficacy endpoints measure all comers OS PFS and DMMR PFS, additional response rate and duration of response. So in primary advanced or recurrent endometrial cancer, RUBY Part 1 included patients with broad disease characteristics, that is FIGO stage 3 or 4 disease, including those with more aggressive histologies such as carcinosarcoma around 9%, and again serous adenocarcinoma 21%. These are all aggressive histologies. So this study included these histologies also as compared to the other studies. And again, the measurable disease with stage 3A, 3C1 or measurable or non-measurable disease with the stage 3C1 patients with carcinosarcoma, clear cell, serous or mixed histology. And again, stage 3C2 or 4. And the first recurrent endometrial cancer with a low potential for cure by radiation therapy or surgical alone or in combination, including those naive to systemic anti-cancer therapy and who had received prior neoadjuvant or adjuvant systemic therapy and who had recurrence or disease progression after or 6 months of completing treatment, first recurrence. So this is the patient with diverse disease characteristics, the RUBY Part 1 study. So again, it's showing median age 65% or older or 48%. So majority of them are more than 65 years, almost half of the cases. Race, again, majority were whites, and DMMR was seen in 24% of the cases. If you look at the histology, majority around 54% are endometrioid, and then comes the 20.4% are serous adenocarcinomas, 10.2% are carcinosarcomas. And again, few other histologies, which includes clear cell adenocarcinoma, mucinous, undifferentiated carcinoma, mixed carcinoma. These are all other histological subtypes, which all constitutes around 14.3%. 7%. Again, the disease status, 18% were stage 3 FIGO, 34% were stage 4, and 48% were recurrent disease. So the major endpoint with respect to median overall survival, favoring a combination of dostarlimab with chemotherapy, 16.4 month improvement, 44.6 months versus 28.2 months, showing a good suppression of the curve and suppression till the end. So the estimated Kaplan-Meier probability of overall survival at 24 months was 70.1% with Jemperli versus 54.3% in the placebo arm with chemotherapy. It all shows that the good benefit with respect to overall survival with the use of dostarlimab with chemotherapy. And again, the one more major endpoint, the 1-year median PFS in a population that included those with aggressive histologies. So I have told what are those aggressive histologies. Again, it is showing statistically significant hazard ratio with a 36% reduction in the risk of progression or death with Jemperli plus chemotherapy versus chemotherapy alone. This is again the Kaplan-Meier curve showing the suppression of the curve, the differences at each time point showing that benefit of Jemperli over placebo along with chemotherapy. So again, more patients achieved overall response rate with dostarlimab with chemotherapy versus chemotherapy alone. The overall response rate was 70% versus 64.8%. And again, the complete responses are also better, 25% with the Jemperli and also around 20% with the chemotherapy alone. And again, the median duration of response with dostarlimab with chemo was 10.6 months as compared to 6.2 months with chemotherapy alone. So all favors the benefit of overall survival, progression-free survival, and also the overall response rate, including the duration of response. So again, the median PFS was not estimable with Jemperli as compared to 7.7 months with the chemotherapy alone arm. So we can make out the curve a very good clear separation of a long duration of almost from 10 months. It's a very good separation. So it's a very good PFS benefit, which was not estimable with the Jemperli, showing a very good benefit in patient with dMMR and MSI high patients. So that's very excellent response in patient with dMMR and MSI high patients. And again, in the same group of patients, the median overall survival was not estimable with Jemperli plus chemotherapy, and it was at 31.4 months with the chemotherapy alone. So all favoring very good, wonderful benefit with the use of dostarlimab, especially in patient with dMMR and the MSI group of patient. The magnitude of benefit is actually very good, and also it has not reached the median so far with around 3.5 to 4 years of follow-up. So again, the additional endpoints, more patients achieved overall response rate, 30% have complete response with dostarlimab as compared to only 20% with the chemotherapy alone, including good overall response rates, 77 versus 69%. And again, the duration of response was also not estimable with the Jemperli arm as compared to the chemotherapy alone, which was only 5.4 months. So in the MMR proficient or MS stable, so 7-month difference in median OS observed with the dostarlimab arm favoring that. And again, it was 34 versus 27 favoring 7 months difference in patient with MMR proficient. So this is the dosage regimen of Jemperli in combination with Paclitaxel. The recommended dosage of Jemperli in primary advanced or recurrent endometrial cancer, it's once in 3-week cycle for 6 cycles, followed by the maintenance therapy of Jemperli. It's 1000 mg, double the dose and double the duration of schedule. So it's total for a duration of 3 years. So this is what the dostarlimab is indicated in combination with Paclitaxel for treatment of adult patients with primary advanced or recurrent endometrial cancer who are candidates for systemic therapy. This is the subgroup analysis. This I discussed the different testing what we do for all patients, the dMMR, pole mutation, non-specific molecular profiling, and also the T53. So this I have discussed the first curve, dMMR, showing a very good separation With pole mutation, of course, we may not expect to see any difference because it's a very good prognostic disease. So, and again, with respect to non-specific molecular profiling, also it is showing the benefit. In this group of patients, the hazard ratio is 0.77. Overall survival also some benefit, 0.87, with some suppression of the curve. And when it comes to the T53, which is a very poor prognostic disease, in the presence of this mutation, this combination of dostarlimab plus chemotherapy has shown a good suppression of the curve with hazard ratio of 0.55. It's actually very excellent. Not only that, PFS benefit and also overall survival benefit of with hazard ratio of 0.41. So even in patient with TP53, they are all poor prognostic group of patients. The dostarlimab with chemotherapy has shown a good benefit over chemotherapy alone. So it's also a good option for our patients with TP53 mutation. So subsequent immunotherapy use, as you can make out here, the immunotherapy. So again, some patients have received a subsequent immunotherapies around 50%. Further with DMMR, and again 69% in the chemotherapy, and this is with respect to proficient group of population, and overall 35% and 54% in the placebo group. What about PFS2 in patient with DMMR? So again, this IVO was used in around 70% of the patients who received further down the line chemotherapy in placebo plus chemotherapy arm. It's showing a very good benefit of PFS2 in the group of patients with the DMMR or MSI population, good suppression of the curve, and it was not reached the median with dostarlimab, and it's a placebo, it was 21.6 months. So all showing a very good PFS2 benefit even in patient with DMMR MSI population. PFS2 results overall, this is again showing a good benefit with MMR proficient or MSS stable population, some suppression of the curve, overall population also some suppression of the curve. So it's you can see clearly make out the difference with respect to dostarlimab and chemotherapy versus placebo plus chemotherapy. It's clear-cut benefit with respect to PFS2 in MMR proficient, and also the overall population. Again, overall population, there is a good suppression of the curve. So it's showing all the very good benefit with respect to PFS2 in patients with even proficient MMR. Okay. Then adverse drug reaction. Again, you know that Jemperli plus paclitaxel exhibited a manageable safety profile. So of course, the common side effects, what we expect is mainly the infusion reaction in the beginning, and then rashes, and then thrombocytopenia. All these were known to seen with any immunotherapy drug. And again, hypothyroidism, which is most of the time it is irreversible, it's irreversible only, and then rash, arthralgia, and then other liver enzyme alterations, and serious adverse reactions occurring in around 39% of the patients with Jemperli in combination with paclitaxel. The most common were the sepsis and pulmonary embolism. So fatal reaction occurred in 0.8% of the cases in the Jemperli arm. So this is what the immune-mediated adverse reaction can occur at any time during the start of PD-1 or PD-L1 blocking antibody. Again, these reactions manifest during the treatment. They can manifest even after discontinuation. And these adverse reactions can be severe or fatal and can occur in any organ, system, or the tissue. It's all, we know all these toxicities very well because we are all very well versed with the use of immunotherapy last 5-6 years. So I think all of you know that all these ITs with respect to each organ. So recommended dosage modification, there is dose reduction of Jemperli is not at all recommended. Only there is a dosing delay or discontinuation may be required only for individual safety or tolerability. And a recommended modification to manage adverse reactions are summarized in the coming slide. And any grade 3 immune-related adverse events we should permanently discontinue, and also the even grade 4. So this is what the dosage modification with respect to pneumonitis. colitis, hepatitis, diabetes mellitus, hypophysitis, hypothyroidism. I will not go into this in detail because will refer all these guidelines whenever the patient have all these toxicities. So we can refer when as and when required. Again, nephritis, exfoliative dermatologic conditions, Stevens-Johnson syndrome, toxic epidermal necrolysis, DRESS, and then myocarditis, neurological toxicities, immune-related adverse reactions, and again recurrent of immune-related adverse events. All these are known, again, infusion reaction. So important safety information. So infusion-related reaction can be infusion-related reaction, which can be sometimes severe, grade 3 or grade 4. We should stop the infusion and permanently discontinue. And again, there are fatal other serious complication can occur in patient who have received a allogeneic hematopoietic stem cell transplant before or after being treated with PD-1 or PD-L1 blocking antibody. So to summarize, the patients with the primary advanced or recurrent endometrial cancer, Jemperli, that is dostarlimab plus paclitaxel on IO combination with a statistically significant overall survival benefit in all comers versus chemotherapy paclitaxel alone. The 16-month improvement with respect to overall survival for all comers, and there is also a significant overall survival benefit with good hazard ratio of 0.69. And again, the pre-specified exploratory analysis in patient with deficient MMR, the median OS was not reached. Versus 31 months with chemotherapy alone, with 3+ years median follow-up. And again, pre-specified exploratory analysis, there is a 7-month improvement in median overall survival was seen in patient with Jemperli plus chemotherapy. And it's a robust trial design, including aggressive histologies, long median follow-up. To date, for an IO combination, that is 3+ years, it's all with a manageable safety profile. So again, it should not be used during pregnancy, lactation, and again, any patient, any females with a childbearing potential should use contraception. This is all the safety data. So with this, I will close. Any questions? Okay, if no questions, we'll move on to the next talk. So the next talk is sponsored by MSD by Dr. Shweta S, consultant medical oncologist from Sparsh Hospital. She will be talking on shifting paradigms in treatment of renal cell carcinoma with immunotherapy. So over to you, Shweta.
Thank you, sir, and thank you all organizers for the such wonderful knowledge-packed sessions. Can I share the slides on my own?
Yeah, you can share.
Oh, yeah.
Yeah, visible.
Yeah. So this session, as already sir has told, it's a sponsored one. So mainly it is about the Keynote 426 trial. So we all know like how well immunotherapy has changed the management in renal cell carcinoma. So this is the overview of my presentation: epidemiology of renal cell carcinoma, stages and their treatments, guidelines of treatment, and current treatment options, including pembro and axitinib. So and mainly the criteria and inclusion criteria and the outcomes and results of Keynote 426 study trial. So when we look into the epidemiology of renal cell carcinoma, it usually happens more in men compared to women and aged 50 to 70, although these days all cancers are shifting their epidemiology to younger ages. So about 9 out of 10 kidney cancers are RCCs, and most of them are clear cell renal cell carcinomas, which constitute around 60 to 70% of the renal cell cancer cases. So that is the most common histology. So when we look at RCC, we usually tend to treat them based on the anatomic location and based on the histology, whether it is clear cell or chromophobe or papillary RCC. So like I told earlier, most of the RCCs are clear cell type, and sometimes papillary also we get to see. Chromophobe and other varieties are a little rare. So when it comes to anatomical location, it can be a collecting duct carcinoma or a renal medullary carcinoma. And sometimes it can be associated with certain diseases, mainly the renal cystic disease. When it comes to molecular alterations, we do see sometimes MIT family translocation carcinomas and SDH deficient renal carcinomas. And as everyone knows, in young patients, we tend to associate the VHL gene. So this is the key statistics. Kidney cancer is ranked 15th in mortality among cancers in 2020. Highest incidence and mortality of kidney cancer is in Asia region. So although immunotherapy has changed the paradigm a little bit, but still we are still hoping to get furthermore and better treatment options still even today. So this is the global distribution of renal cell carcinoma. Overall, Asia contributes for the majority of cases, followed by Europe. And this is the 5-year prevalence wherein Asia and Europe stand and go hand in hand. Looking at the mortality, contribution. Asia has the highest mortality compared to Europe and other continents, probably due to varying treatment options. And we are not able to give the immunotherapy option for many of our patients still. So risk factors for renal carcinomas are well known and well studied. Increased frequency of smoking, obesity, high blood pressure, genetic diseases such as the VHL disease, hereditary papillary RCCs, and Birt-Hogg-Dubé syndrome or Cowden syndrome. It's 2 times more common in men than women, and a family history of RCC is a significant contributor. So prevalence of RCC approximately 2 times more common in males and more common in the geriatric population. So most common histological subtype is clear cell RCC. Stages of RCC, stage 1 is limited to kidney with a 5-year survival rate of 90%. Sometimes we admit or advocate active surveillance in stage 1 disease. Stage 2 is involvement of perinephric fat, remains limited to geritas fascia, and 5-year survival drops to 50%. Stage 3 is either renal vein involvement or a nodal involvement, and the 5-year survival is much poorer, that is around 30%. Now we have a role of adjuvant pembrolizumab also in stage 3 disease. Stage 4 is usually the direct invasion of adjacent organs or structures or metastatic disease, where the 5-year survival rate drops to less than 10%, although it has improved a bit with immunotherapy. The prognosis depends basically on the stage and histology of this histology of the disease, wherein the papillary RCC 5-year survival rate is much higher compared to the clear cell RCC, although papillary contributes only about 15 to 20% of the cases and clear cell contributes to around 70% of the cases, but 5-year survival rate is only 70% in clear cell subtype. The chromophobe variety scores much poorer compared to papillary and clear cell types. So this is the TNM staging. I won't go into depth. So this is the NCCN guidelines, which lists out all the available options for treatment in the first line clear cell histology. So favorable risk, axitinib, pembrolizumab, cabozantinib, nivolumab, lenvatinib, pembrolizumab, and ipilimumab plus nivolumab. And in the poor or intermediate risk, axitinib, pembrolizumab, cabozantinib, nivo, ipilimumab plus nivolumab is category 1, lenvatinib, pembrolizumab is category 1 again, and cabozantinib also. So ipilimumab plus nivolumab, usually we tend to use only in poor or intermediate risk patients, and it's a category 2A recommendation in NCCN also. It's not mentioned as category 1. For relapse or for relapse setting, we usually, if there is no exposure to prior immunotherapy is the first treatment choice. And if there is prior immunotherapy, we usually opt for either TKIs, changing the TKI, or going for a VEGF inhibitor like cabozantinib, everolimus, or even sometimes bevacizumab. So that's the same thing. So when we look at the combinations of immunotherapy and TKIs that have been tried and tested in renal cell carcinomas, initially bevacizumab with interferon alpha was used long back in 2009. So then came lenvatinib, everolimus, nivolumab, ipilimumab has the highest long-term follow-up, and this was the first immunotherapy that was approved, nivolumab plus ipilimumab as a dual combination. So pembrolizumab axitinib, pembrolizumab lenvatinib, and avelumab axitinib are the other combinations. So today we'll be digging deep into Keynote 426 trial. So the emergence of immune checkpoint inhibitors and combination therapies has actually revolutionized the treatment of clear cell RCC. There is a significant improvement in efficacy profiles, as we'll see through the next slides. So combination therapy, that is pembrolizumab and axitinib. The development history of immunotherapies in RCC, like I told, initially there was the interleukin-2, interferon alpha, which was tried long back, and then ipilimumab phase 2 trials happened in 2007. Then they tried a combination of ipilimumab and nivolumab, which then later got approved in around 2015. So then other immunotherapies were also tried, and finally we are at the level where we have multiple options now, and we try to choose them on some basis, some or the other basis, usually on minimal differences. So immunotherapy strategies in renal cell carcinoma. So like I told, it could be the cytokine immunotherapy, which was previously interleukin-2, interferon alpha. Some vaccines were also tried with the dendritic cell vaccine and recombinant vaccines. So monoclonal antibodies, that is the pembro or anti-PD-1, PD-L1 or anti-CTLA-4 or even the anti-VEGF inhibitors, which are the targeted therapy agents. So CAR cells are also being evaluated and being studied. So mechanism of pembrolizumab, we all know it is an anti-PD-1 inhibitor, wherein it goes and binds to the PD-1 receptor present on the cytotoxic T cells, and it activates and enhances the activity of T cells and immune cells to fight against the tumor cells. And adding axitinib to this particular drug, actually axitinib is a VEGF receptor, tyrosine kinase inhibitor. So this potentiates the action of pembrolizumab, so mainly by acting against VEGF receptor. So its advantages over other TKIs are, the main thing is like it has a shorter half-life of around 4 to 6 hours. So thereby, even if there is a side effect, once you stop the drug, the reversal of side effect happens faster compared to other TKIs. And also it has it requires very less concentration to have an effect compared to other TKIs, as studied in the preclinical trials. So this is the rationale for combination of VEGF and pembrolizumab. So angiogenesis inhibition can increase T cell infiltration and enhance anti-tumor activity by decreasing the effect of macrophages and other stem cells. Overall, anti-VEGF therapy with immunotherapy is an important strategy, improving survival in patients with metastatic RCC. So this combination treatment, that is Keytruda or pembrolizumab, is indicated for the first line treatment of advanced RCC in adults. So pembrolizumab is administered as an IV infusion over 30 minutes, 200 mg every 3 weeks in the standard dose. So this is the Keynote 426 I was talking about, pembrolizumab plus axitinib versus sunitinib as first line therapy for advanced clear cell RCC. So unfortunately, we don't have any trials which compare, IO TKI versus another IO TKI, because all of these trials were done in an era where, TKIs like sunitinib were the standard of treatment. And we don't really expect them to have a randomized trial between these arms, because we know that this is the standard and all have similar survival benefits. So the key eligibility criteria for Keynote 426 was newly diagnosed or recurrent stage 4 clear cell RCC, no previous systemic treatment for advanced disease, and measurable disease as per RECIST version 1.1. And the stratification factors were based on IMDC risk group, that is favorable versus intermediate versus poor, and geographic region. So the arms were pembrolizumab 200 mg IVQ 3 weekly for up to 35 cycles or approximately 2 years, plus axitinib 5 mg orally twice daily, versus sunitinib 50 mg orally once daily, a 4-week on and 2-week off cycle. So endpoints were that there was a dual primary endpoint, that is PFS and OS, and key secondary endpoints were overall response rate and duration of response and safety. So this was the baseline characteristics, and it was well distributed. Pembrolizumab plus axitinib versus sunitinib. So age was 62 median age, with males and almost equal numbers, 308 versus 320. So region of enrollment were also similar. IMDC risk category, favorable versus intermediate versus poor, were also equally distributed among both the arms. Sarcomatoid features were also almost similar in both the arms. And PDL1 and more than or equal to 2 metastatic sites, whether prior nephrectomy was done or not. So all these arms were actually equally distributed. So, yeah. So this is the overall survival in intention to treat population. So the Kaplan-Meier estimates showed a significant overall survival benefit. The risk of death was 47%. So in the pembrolizumab axitinib, 47% less in the pembrolizumab axitinib group than in the compared to the sunitinib group, with an hazard ratio of 0.53 and confidence interval well within well less than 1, that is 0.38 to 0.74. That is, all the patients benefited with pembrolizumab axitinib compared to sunitinib arm. That was a significant hazard ratio. So when the subgroup analysis of overall survival was done, you can look at the forest plot, wherein all subgroups are have shown a benefit irrespective of the age, whether less than 65 or more than 65, male versus female, region of enrollment, IMDC risk category also favorable, intermediate, poor, performance status score, PD-L1 positivity, number of organs with metastasis. So all the subgroups actually showed that pembrolizumab axitinib arms performed better compared to the sunitinib arm. So this is the Kaplan-Meier estimate for progression-free survival in intention to treat population. So if we look at the hazard ratio for disease progression or death, it was 0.69. So there was 31% lower risk of progression with pembro axitinib compared to the sunitinib arm. So subgroup analysis for progression-free survival also didn't show any deviations. So only like there was a few patients probably who didn't benefit with pembro axitinib, as shown by the more higher confidence interval, that is more crossing the line. So otherwise, all patients benefited with the pembrolizumab and axitinib compared to the sunitinib arm. So pembrolizumab plus axitinib versus sunitinib, the 5-year analysis also shows the similar results. So 861 patients were randomly assigned with pembrolizumab axitinib, 432 were assigned and 429 were treated, and in sunitinib arm 429 were assigned and 425 were treated. Similar numbers, not significant difference. So out of them, 30 are still ongoing treatment, and that is 7% are still ongoing treatment, and 88.8% discontinued, wherein 227 had a radiographic progressive disease, 92 had adverse events, 21 patient decision, 14 clinically progressive disease, and 14 physician decision, and other factors. So similar results were also seen in the sunitinib arm, wherein 19 had ongoing treatment, that is half of the pembro axitinib arm, and 95% of the patients, that is more number of patients, actually had a treatment discontinuation in sunitinib arm. 260 had radiographic disease, radiographically progressive disease, 82 adverse events, 26 patient decision, and 17 clinically progressive disease, and 17 physician decisions. So when we look at the progression-free survival at 5 years, so hazard ratio was 0.69. That is there was a 31% reduction in the progression with pembrolizumab and axitinib arm. The median progression-free survival was 15.7 months versus 11 months with sunitinib. So this is very important slide, wherein we look at the complete response, because we all know, like, the patients who respond are the ones who will have a long durable responses with immunotherapy, and they are the ones who actually drive the curve very much. So here the patients on pembrolizumab plus axitinib arm had a 11.6% of complete response compared to only 4% with sunitinib arm, and 49.1% partial response, 22% stable disease. So the overall response rate, which included the complete response and partial response, were around 60%. The only IO TKI combination which has a superior overall response rate is the pembrolizumab lenvatinib, but unfortunately it's a regimen which has higher toxicity profile, and we don't usually use that because of the toxicity profile. So when it comes to the overall response rates, like, all the available options usually fare similar in terms of around 60% overall response. So the duration of response was also significantly higher compared to the sunitinib arm. So the median duration of response with pembrolizumab axitinib was around 23.6 months compared to only 15 months with sunitinib arm. So it was like at 3 years, the difference was 37 versus 29%. At 4 years, it was 28% versus 20%. So, and at 5 years, it was 26 versus 14%. The longer the duration, the difference became significant, which explains that most of the immunotherapy agents, when immunotherapy patients who respond initially well, they are the ones who can have a longer duration of response, and they tend to fare very well over the coming years. So overall survival in the intention to treat population also. So the pembrolizumab axitinib arm had a median OS of around 47 months compared to 40.8 months with sunitinib arm. And many of the patients who received sunitinib actually had an exposure to immunotherapy in the later lines, which will come in the next few slides. So
Last 2 minutes.
yes, sir. So hazard ratio was 0.84 when coming to overall survival at 5 years. So this is IMDC favorable risk. In this also there was a minor difference. It's approved for use in favorable risk also, but the difference is actually very significant for a poor and intermediate risk patients. So favorable risk overall response rate was around 68% compared to 50% in the sunitinib arm. So pembro-axitinib versus sunitinib, that's the statistics wherein they started treatment and discontinued treatment. We all know, like, even after discontinuation, sometimes immunotherapy can still work better. So this is the characteristics of patients who completed 2 years of pembrolizumab maintenance. So at least some 25% of the patients actually were able to complete the treatment. So patients who completed 2 years of pembrolizumab, the overall survival was around 94% and at 3 years and 70% at 5 years. So summary of adverse events, it was nothing different from what we see in our patients usually. So the same immune-related adverse events were observed here also. So summary, it represents the longest follow-up to date of the combination of IO plus TKI. So, and it continued to demonstrate improved OS, PFS, and overall response rate versus sunitinib for patients with previously untreated clear cell RCC patients. So many patients, that is at least 1/4 of the patients, were able to complete the 2 years of treatment. So these data establish it as a standard first-line treatment. So I'll skip the case study. Yeah, thank you for the patient listening.
Thank you, Dr. Shweta. How do you choose now the first line option? So
Yeah,
we have plenty of options.
The highest response is although with pembrolizumab plus lenvatinib, but it's very patients have a very poor tolerance. So none of us usually tend or incline towards the pembrolizumab lenvatinib unless the patient really is very insisting on it. So otherwise, when it comes to pembrolizumab axitinib versus nivolumab cabozantinib, so I have always had patients who were not able to tolerate cabozantinib up to the optimal dose, whatever the dose is advised. So I feel like axitinib is much more easier to handle and manage the side effects compared to cabozantinib. So that leaves us with pembrolizumab axitinib versus avelumab axitinib, which is one more approved combination. And due to logistic issues, most of the times avelumab is little costlier compared to pembrolizumab. And avelumab is given every 15 days compared to pembrolizumab, which can be given every 21 days. So otherwise, the overall response rate, everything is almost similar in both the combinations. But avelumab has a little lesser side effects compared to pembrolizumab as per that study data. So in a patient who has a poor performance status but still wants to, we want to give a IO TKI combination, I might probably choose avelumab TKI, avelumab axitinib. So to give that smaller benefit of whatever less side effects. Otherwise, pembrolizumab axitinib is the most widely used combination. So if the patient is very fit and young, Nivo-IP is definitely the best with maximum.
I think Dr. Akila has something to comment.
Yes. Yes, Dr. Akila, please.
Okay, even I do feel that pembrolizumab is the most tolerable combination of IO TKI than other two combination, and it is also very good survival data and long-term data. It's all very good combination for all patients.
So
Okay.
in papillary RCC, sometimes they say nivo-cabo is better than pembrolizumab, and this study actually particularly excluded that subset in their this thing. So there are some studies which say like nivo-cabo can be tried in papillary. So that is one specific subgroup where I prefer nivo-cabozantinib versus other.
Okay, fine
Okay,
then.
sir. Thank you.
Thank you very much. It was good interaction. So that we have come to the end of all solid tumor sessions. Now let's move on to the hematology session. So with hematology session, the first will be ASCO update on hematology by Dr. Manjunath, Assistant Professor, Kidwai Hospital, Gulbarga. So over to Dr. Manjunath.
Good evening, everyone. Today, I'll be going to present updates on ASCO in hematology. First of all, I would like to thank Dr. Lokesh sir and all the organizers for this opportunity. Are my slides visible?
Not yet.
Now?
Yes, you can enlarge
Okay.
it. Okay, next 15 minutes. Fine. Yeah.
Yes. So, first of all, I'll be presenting two studies which will most likely be practice changing in hematology. Firstly, coming to DLBCL. As we all know, RCHOP had been a first line in treatment of DLBCL for past 2 decades, and there was improvement in PFS and OS in the long term scene. But up to 40% of the patients relapsed or had a primary refractory disease to RCHOP. So there were various attempts done to improve on RCHOP, mainly to increase the dose of rituximab or to intensify the chemotherapy or addition of novel agents. And all these attempts resulted in negative studies, and mainly there were two studies which showed some benefit. One was lenalidomide maintenance, where there was a PFS benefit, and one more was addition of polatuzumab vedotin, that is POLARIX study, where there was improvement in PFS of 5% in 5 years, but there was not any OS benefit. So, to look into this matter, there was a study done where tafasitamab, which is anti-CD19 monoclonal antibody, which with lenalidomide was added to the RCHOP backbone. Initially, in a phase 1B first-line trial, the safety and activity of tafasitamab with lenalidomide was studied with the addition of RCHOP, and presently this is the phase 3 study. So this is a international double-blind placebo-controlled randomized phase 3 study. The patients included were of age 18 to 80 years, and all the patients which were included were mostly high-grade DLBCL or high-grade B-cell lymphoma with IPA 3 to 5 or age-adjusted IPA of 2 to 3. And tafasitamab was given the dose of 12 mg per kg IV, day 1, day 8, day 15, with lenalidomide 25 mg per day, which was given over 10 days with RCHOP. A total of 6 cycles were given, and the primary endpoint was PFS. So these are the baseline characteristics. The baseline characteristics are well matched, and the stage 4 disease included in the study were up to 97%, and the bulky disease was up to 57%, and the high risk disease was up to 41 to 45% in this study. And the cell of origin also were comparable, up to 35% in ABC like and 50 to 55% in GCB like. So there was a PFS benefit which was seen in the study, which was 67% versus 60%, with the hazard ratio being 0.75 and p-value being statistically significant. And PFS across all the subgroups were significant. And when we look at the cell of origin, ABC like had the hazard ratio of 0.59 and GCB like had 0.69. And in bulky disease also there was a hazard ratio of 0.78. And when we look at the secondary endpoints, EFS and OS, the p-value was not significant. And PFS in centrally confirmed lymphoma studies, the p-value was significant. And when we look at the response rate, the PET negative CR rate were similar in both the arms. But one thing which we have to look here is MRD negativity, which was almost 81% in TAFAL and RCHOP versus only 66% in RCHOP. So we showed deeper responses to the treatment. And looking at the safety, grade 3 adverse events were 86% when compared to RCHOP, and the serious adverse events were 50%. And when we look at the type of adverse events, more of hematological adverse events were seen, mainly neutropenia, thrombocytopenia, leukopenia when compared to RCHOP. So, frontMIND is a this study is a primarily analysis of phase 3 frontMIND study demonstrated significant improved PFS when compared to RCHOP. Even though there were increased numerical incidence of grade 3 or serious adverse events, but they were manageable. When we look at frontMIND versus Polaric study, the PFS benefit was 5% here and 7% in this study. And MRD negativity was not assessed in Polarix, whereas it was 81% versus 66% in this study. The grade 3 adverse events were similar in Polarix study, but here it was almost 10% increase, and the major toxicities were hematological. And coming to the next study, which is multiple myeloma. When we come to the treatment options in multiple myeloma, presently anti-CD38 molecules have revolutionized the treatment in multiple myeloma. With the addition of daratumumab or isatuximab with VRD, the benefit in the first line has increased. But as anti-CD38 antibodies are used in the first line, the question arises as to what agents are available in the next line. So when we look at the anti-CD38 refractory, like in the present scenario, there are up to 70 to 80% patients who are refractory to daratumumab in the first line. So the options which are here are carfilzomib, lenalidomide, dexa, carfilzomib, pomalidomide, dexa, or pomalidomide, bortezomib, dexa. And these molecules have a similar mechanism of action when compared to the molecules which are used in the first line. So there was a need of unmet need in this scenario, and here previously teclistamab was used in the setting where four or more prior therapies were used. And in this study, that is Majestic 9 study, here we are evaluating the role of teclistamab monotherapy in the second line setting. That is in the second line setting. So in the Majestic trial, the key inclusion criteria were relapsed refractory multiple myeloma with 1 to 3 prior lines of treatment, and the key exclusion criteria was prior B-cell maturation antigen directed therapy, which was not to be used. The dosing in this trial of teclistamab monotherapy was step-up dosing. Like in the first cycle, there was 5 doses given. In the second cycle, 4 doses, and as the number of cycles increased, the doses reduced in number. And from third to sixth cycle, the dosages were only 2. And if the patient had achieved VGPR by fourth cycle, the monthly dosing of teclistamab was used. And when we look at the steroid usage in this study, the patient only received steroids in the cycle 1, that is on day 1, day 3, and day 5. The other arm was pomalidomide, bortezomib, dexamethasone, and or carfilzomib, dexamethasone, and the primary endpoint was PFS. So when we look at the baseline characteristics, the baseline characteristics were well matched, and the median age was 70 years in this study. And the ISS stage 3, the patients were 42% in the teclistamab arm, and the soft tissue plasmacytoma were 18%, and high risk cytogenetics were 35%. When we look at the prior lines of treatment in this study, the median prior line of treatment were 2, and the patients who had received 3 or more prior lines of treatment were 35%. And the refractoriness in this study was almost 92%, and almost 85% in this study were anti-CD38 refractory. So the median 18-month PFS in this study was 69% versus 26% in the PVD or KD arm, with hazard ratio being 0.29. So there was 71% reduction in the risk of disease progression of death in a highly refractory setting. And when we look at the subgroup analysis, there was benefit seen across all the subgroups, and even the elderly patients did well with the study. And when we look at the response rate, CR rate were around 53% when compared to only 9%. And the overall response rate was 84% when compared to 54%. So there was a statistically significant overall response rate with CR rate increased to more than 4 times when compared to the control. And durable responses were seen. And estimated 18-month duration of response was 18% versus 40%. And MRD negativity. MRD negativity in the intention to treat analysis was almost 38% versus 6%. There's almost 6% increase. And in the evaluable analysis set, it was 86% versus 45%. So when we look at the OS data, there is OS benefit seen in the study 79% versus 62%, with hazard ratio being 0.60 at 18 months. And when we look at the overall safety profile, CRS and ICANS were seen, but were infrequent and when low grade, and the treatment discontinuations were almost similar in both the arms. When we look at the infections, that is grade 5 infections, which were 5.5% in teclistamab arm versus only 2% in the other arm. And hypogammaglobulinemia was seen in both the arms, 69% versus 50%. Even though the grade 3, grade 4 infections were frequent, there was a diligent use of immunoglobulin therapy and antimicrobial prophylaxis. And what was seen with the study was the infections, even if they were seen in grade 3 or grade more setting initially, the frequency of infection declined over time. And when we look at the time to worsening of multiple myeloma symptoms among both the arms, it was not reached in teclistamab arm versus 19 months in the control arm. Hazard ratio being 0.50. So when you look at the conclusion, teclistamab monotherapy when compared with the pomalidomide, bortezomib, dexamethasone, or carfilzomib, dexamethasone, there was superior PFS benefit seen with hazard ratio of 0.29 and overall survival of hazard ratio of 0.60. Infections, even though were seen, were infrequent after 6 months, and CRS and ICANS were mostly grade 1 and managed with the established protocols. So when we compare other anti-CD38 refractory therapies, the median PFS was not reached in teclistamab study at 18 months, and the CR rate was very high when compared to other anti-CD38 refractory therapies after first line. So take home messages in the frontMIND study, which was done in mostly high-risk DLBCL patients. It was the first positive phase 3 study demonstrating addition of tafasitamab with lenalidomide with R-CHOP. The benefit was consistent across all the subgroups, and higher MRD negativity was seen in the experimental arm. Even though the hematological toxicities were more, but they were manageable. OS data is immature as of now. And when we look at the Majestic 9 trial, teclistamab monotherapy significantly improved both PFS and OS compared to the control arm. There was a manageable safety profile. This study supports teclistamab as a new standard of care option from second line onward.
Okay, thank you, Manjunath, for excellent talk. So, do you think the frontMIND will replace the Pola CHP now? Hello? Hello, Manjunath? Okay, Mahesh, you want to take this?
Yeah, so
Tafasitamab?
possibly there will be a subset of patients like DLBL, as you can understand, has become quite a heterogeneous disease now.
Mm-hmm.
It will be very individualized approach with the next generation sequencing and gene chip coming into picture.
Yes.
It will not be treated as a single disease henceforth.
Okay.
Just like what we have been doing for other hematological malignancies, let it be AML or let it be any other hematological malignancies for that matter. DLBL will be totally like there will be 7 to 8 subsets based on the gene chip, and based on what molecules they express, we determine the treatment goals.
So future is
obviously,
a NGS for all the DLBCL.
right now, no, but probably in the future we'll definitely use it because we have seen the clear differences in the way they respond, and the molecules which we want to use upfront is determined very often by the molecular signatures which the DLBL expresses.
Okay.
This is available in India? It's not there.
No, not yet.
Not available, sir. Not yet available,
Yes,
sir.
we can do it on the biopsies, but it is not standardized.
Okay. For this
No,
also we need that
tafasitamab.
NGS testing.
No,
Pardon?
sir. NGS testing per se was not done in this study, sir. They had used in all the patients.
Okay.
Okay, then I think with that, we'll move on to the next session. It's sponsored by AbbVie, by Dr. Mahesh or consultant hematologist at Sparsh Hospital. So over to you, Dr. Mahesh.
I am not able to share because the host isn't allowing me.
They will allow you. Yeah. Mhm.
So, as you can understand, again, CLL has become quite a easy disease to treat now. The reason why it has become a easy disease, and more or less now you can treat this disease just like the way you are treating diabetes and hypertension, with a little bit of care when it comes to upfront risk stratification, and also notifying what are the toxicities of the individual molecules which we have been using in the treatment of CLL. In CLL, the days of chemoimmunotherapy is gone now. It is more of a targeted therapy, and more often you hang around either a BTK inhibitors, BCL2 inhibitors, plus or minus obinutuzumab with or rituximab. So these combinations have changed the way by which we treat chronic lymphocytic leukemias. However, the conditions or the indications to treat chronic lymphocytic leukemia remains the same, and the prognostic risk stratification remains the same. A lot of studies are relying very heavily on the minimal residual disease. And I think even in India, we should follow using this minimal residual disease approach, because uh, the patients who achieve undetectable minimal residual disease, they respond dramatically, and the DFS and EFS are much more superior when compared to the patients who have minimal residual disease. So the days of chemoimmunotherapy is gone for CLL, and it is era of only targeted therapies. Probably only place wherein I use bendamustine rituximab for my patients with CLL are one, unaffordability, and patients who have very standard risk without P53 mutation, 17p deletion, or maybe an mutated IGHV status. That is the only place wherein sometimes I use bendamustine rituximab as against the standard therapy because of cost constraints. As you can see here, definitely the patients who achieve undetectable minimal residual disease, they go a long way into their disease course. Sometimes they may relapse after 5 years, 10 years down the line rather than relapsing early. But as you can see here, somebody who has got a clinical disease or who has got a measurable disease, they relapse much earlier and they become clinically symptomatic very earlier in the disease course. Hence, our approach in the treatment of CLL going forward should be to achieve unrelated MRD at the end of limited duration of therapy. So previously, when we were using only ibrutinib or acalabrutinib, it was the endless therapy, and lot of cost constraints were there because every month they used to spend like 20,000-30,000 rupees, and overall a lot of patients would die because of the continuous exposure to these immunotherapies resulting in infections. What is venetoclax? Why it has changed the course of disease of CLL, and how is it better when compared to just single agent acalabrutinib or chemoimmunotherapy? Let us discuss here. So venetoclax is a selective first in a class BCL2 inhibitor. As you know that CLL cells express this anti-apoptotic protein called as BCL2, what venetoclax does is it displaces the pro-apoptotic proteins from the BCL2, and these pro-apoptotic proteins, as you can see here, dimerize on the mitochondrial membrane. They create holes in the mitochondrial membrane and promote apoptosis. That is how venetoclax acts, by promoting apoptosis by displacing the pro-apoptotic proteins from the BCL2. You can see here clearly that the CLL cells express BCL2 in excess, and venetoclax, what it does is it selectively inhibits the BCL2, and especially along with combination with obinutuzumab in CLL14 study and rituximab in Murano study, you can see that there is a lot of synergistic effect and lot of cell kill happens because of the apoptosis. So now what is the advantage of using the venetoclax based therapy is that it is a limited treatment exposure. You know exactly when the treatment is going to end, because when you are using a combination of venetoclax with obinutuzumab, you can clearly tell the patient the treatment gets over in 12-month period. And when you are using with rituximab, you can clearly tell the patient that the treatment is going to get over in 2-year period. And hence, you can definitely tell the patient what is the fixed cost for this complete duration of therapy. Now, with this background, let us see what some of the studies involving venetoclax with obinutuzumab. The landmark study was the CLL14 study, wherein the patients were randomized 1:1 for the combination of venetoclax and obinutuzumab versus chlorambucil with obinutuzumab. As you can see here, obinutuzumab starts first, and venetoclax is usually a ramp-up dose over a 5-week period, and venetoclax starts from second cycle only. And the ramp-up dosing of venetoclax is very important because it can cause significant cell kill and it can cause tumor lysis syndrome. The usual selection criteria for this study was the previously untreated CLL patients, coexisting medical conditions with a creatinine clearance of less than 70 ml or a CIRS more than 6 were also accepted. Most of these patients were in the age group of more than 18 years. The primary endpoint was a progression-free survival. However, the other secondary endpoints were also studied. Clearly, at 2-year progression-free survival, you can see that it is 88% for ven obinutuzumab group versus 64% for obinutuzumab with chlorambucil. But at the end of 6 years, you can see that there is a clear-cut difference in the progression-free survival. It is only 22% for the chlorambucil group, and it is 53% for the venetoclax group. And similarly, our goal, as I already said, is to achieve minimal residual disease. Let it be in the blood, let it be in the bone marrow, because patients who achieve minimal residual disease have a disease-free survival and overall survival for a much more longer period of time when compared to the patients who do not achieve unrelated minimal residual disease. And this is achieved to a 2 times greater extent in the blood for ven group and 3 times to a greater extent in the group which has chlorambucil. And also you can see the complete remission rates were also significantly higher in ven obinutuzumab group. It was like almost like 50% in the ven obinutuzumab group as against the chlorambucil group. Now, what you are also concerned is because these are chronic diseases, CLL go on for many years and maybe for lifelong, you are interested in when would my patient require a second treatment. As you can see here, 65% of the patients will be treatment free with ven obinutuzumab for a very long duration of period of time as against chlorambucil arm, which is up to an extent of 37%. Now, you would be interested to look into the other data. How would my patients fare when they have a high risk mutations, especially the TP53 ones and IGHV unmutated ones? You can see that the forest graphs are always skewed towards left, indicating that when obinutuzumab is much superior to chlorambucil when it compares to high-risk groups like T53 mutations and IGHV unmutated ones. However, not much of differences in overall survival. You can see that there is hardly a 10% difference in the overall survival between the obin group with venetoclax against chlorambucil obinutuzumab group. Now the CLL13 studied, you are interested to look into that. Chlorambucil, you are not interested because you have always been using FCR and BR in your recent practice. You want to understand how would venetoclax obinutuzumab fare against FCR, BR. Clearly, you can see that undetectable MRD was much more superior with when obinutuzumab group as against the FCR-BR group, and complete remission along with the complete remission and incomplete bone marrow recovery were much more higher in the when obinutuzumab arm against the FCR-BR group, and more so the time to next treatment would be less required for the patients who would receive when obinutuzumab as against FCR and bendamustine. So safety profile, you can see that it is safely placed against BR and FCR. There were more infections, especially the grade 3-4 infections were more in the BR FCR group as against the when obinutuzumab group. Second malignancies, since they were exposed to chemotherapy, FCR and BR group had more second malignancies as against the when obinutuzumab group, and fatal adverse events were also comparable between the two arms. So safety profile, when obinutuzumab fared more safer when compared to FCR or BR. Now, obinutuzumab is much costlier. So you want to understand how would my patients fare when you are using venetoclax with rituximab. Unfortunately, this combination has been not tried well in the upfront CLL groups. However, there is a lot of data in the relapsed refractory chronic lymphocytic leukemias, especially coming from the Murano study, wherein the venetoclax was combined with rituximab. Rituximab was given at a dose of 375 milligram per square meter in a first cycle, and subsequent cycles rituximab was given at 500 milligram per square meter. And after 6 cycles of the combination, venetoclax was continued for 18 months. And BR, everybody knows how it is given. It's 70 milligram per square meter of bendamustine with rituximab. However, some of the high-risk groups were excluded from the previous study which I mentioned. Now here you can see that there is a significant progression-free survival benefit for the rituximab with venetoclax as against BR. There is a significant differences in the graphs as you can see here. Also, the undetectable MRD status was 4 times higher in the peripheral blood and much more higher even in the bone marrow as against the bendamustine rituximab. Complete remission rates as well as complete remission rates with incomplete bone marrow recovery were also much higher with the when rituximab as against the bendamustine rituximab. And also all groups including the high risk groups fared much better with when rituximab as against the conventional bendamustine rituximab. So based on these data, you can clearly say that when rituximab fared much better in the relapse refractory CLL as against the bendamustine rituximab. Now, everybody wants to understand how do I use it in my practice? What are the usual side effects which I see in my practice? The commonest side effects which I have seen in my practice is the infections, especially the pneumonias, upper respiratory tract infections. Cytopenias you need to clearly monitor with every cycle and more frequently, especially in the first cycle. Neutropenias are very common, lymphopenias are very common. So you need to give HSV prophylaxis. They have to be on PCP prophylaxis. Sometimes you may have to monitor immunoglobulin levels, especially if they are having repeated infections. The dyselectrolytemias, especially in the first cycle, is very common because of the tumor lysis syndromes. GI disturbances are one thing which you see very frequently when you are using with obinutuzumab, especially the mild diarrheas are very common and patient usually require loperamide for that treatment. However, grade 3 toxicities like fulminant diarrheas or projectile vomiting causing dehydration are less common. Usually, most of the patients experience some fatigue and some increase in creatinine. As I have seen, the most important thing which I have seen in the long-term venetoclax use is some increase in creatinine, which may require dose modifications. And usually these are all pretty much manageable, and we have not lost any of the patients for venetoclax therapy. And we have much data also coming from AML, wherein we have used safely in at least more than 100 to 200 patients. And even in CLL, we have around 4 to 5 patients wherein we have used this combination of venetoclax and obinutuzumab. First 4 weeks, you have to be very careful because tumor lysis syndrome risk is very high, especially for patients who have a high burden disease, especially one with a bulky lymph nodes, one with a white cell count of more than 25,000. You got to be really very careful. And also sometimes you experience this cytokine storm happening in the first cycle, and a lot of these patients can develop pneumonitis kind of a picture and significant liver dysfunction, which you need to be really very careful. And sometimes to manage this cytokine storm, especially in the first cycle, you may require steroids. Now, as I already said, you need to be very careful while you are using venetoclax in the first 4 weeks, because there is a lot of tumor lysis syndrome which happens in the first 4 weeks. And based on the tumor burden, you need to decide whether you want to give allopurinol, whether you want to give raspuricase, whether you want to manage these patients as an outpatient or an inpatient. All this is determined by what is the tumor burden of the disease. And also you need to be very careful using venetoclax with a strong CYP3A inhibitors or a moderate CYP3A inhibitors. Just like that, for other patients, you cannot give azithromycin, you cannot give ciprofloxacin, you cannot give fluconazole because you need to monitor QTc interval for these patients. So you got to be very careful when you are using venetoclax along with other strong CYP3A inhibitors, and lot of drug modification is required. And hence, if you want to dose reduce because of the cost constraints, sometimes what we have done is we have used fluconazole or posaconazole, and sometimes we have used even erythromycin if the patients are unaffordable for the full dose 400 mg of venetoclax. So the only contraindication to use venetoclax is when they have a hypersensitivity reactions, and especially when there is a concomitant use of strong CYP3A inhibitor, sometimes you may have to titrate the dose. Significant renal impairment or hepatic impairment could be a contraindication, and especially when there is a hepatic impairment, you may have to reduce the dose by 50%. So with this data, I would say that in your future practice, probably for all high risk as well as standard risk CLL, the go-to-go combination would be venetoclax obinutuzumab, because you are changing the way the patient leads his life. They will be treatment free. A lot of these patients will be able to achieve deeper responses with undetectable MRD status. Lot of these patients will not require second line therapy in their lifetime, because many of these patients are fragile, old, and lot of these patients will not require second line therapy, especially if you are using venetoclax with obinutuzumab in the upfront therapy. Thank you for giving this wonderful opportunity. And thank you, Abby, for providing the slides.
So thank you, Dr. Mahesh. It was excellent talk. So now we have 3 drugs in CLL first line. All combinations are there.
Yes. Yeah.
So how do we choose for our patient?
So that is a very nice question. So what is most important is, one, in a given Indian scenario, of course, the financial constraints are always there, which need to be taken into consideration. And most importantly, what you need to consider is whether your patient is at risk of cardiac events. If your patient is at risk of cardiac events, cardiac arrhythmias, accelerated hypertension, having ischemic heart disease say no to ibrutinib or acalabrutinib. Those are the patients which would be benefited by using venetoclax. Also, ask your patient whether he requires a definite duration of therapy or an indefinite duration of therapy, just like diabetes or hypertension. He just wants one pill and he wants to take it forever. Then you can choose either acalabrutinib or the newer BTK inhibitor like zanubrutinib.
I think nobody will choose for long duration.
Pardon?
Nobody will choose for lifelong treatment.
No. Sometimes patients, also fragile patients, especially one with a lot of toxicities, or you feel that patient does not have a poor, does have a poor renal reserves, poor lung reserves, wherein you cannot use a dual combination. Those are the subset of patients wherein you just give a single agent therapy,
Single agent.
especially if they
Okay,
are
okay.
very fragile. Those are the subset of, and also most importantly, whether your patients are having these high risk mutations like P53 mutations and
Yeah.
IGVH unmutated status. Those are the subset of patients wherein you use a combination therapy like obinutuzumab.
To young fit patient, you think for them also no role of FCR now?
I think the days of FCR are gone now. Even for young fit patients, you can see the data from the CLL13 study that the main goal is to achieve undetectable MRD. However, MRD for CLL are not standardized in India. Finally, going ahead, your goal should be to achieve undetectable MRD status so that patient can remain disease free for a very long duration of time, and time to second treatment is much longer for a very long duration of time.
Okay. And when it comes to venetoclax dosing, will you be able to achieve full dose for majority of your patients?
Yes. We have been able to give 400 mg. We have around, but most of these patients are young patients. They are in their 40s and 50s. We have given obinutuzumab full dose. As I already said, first 4 weeks you have got to be very careful, and rest of the time it is very easy to manage this combination of obinutuzumab. We did not have any major toxicities. Only most of these patients tend to have creatinine on a higher side. Sometimes with fourth, fifth cycle, the creatinine goes to 1.8, 1.92. There you have to dose modify or temporarily withhold venetoclax so that their renal parameters come down to normal and again restart with the same dose. We have been able to give 400 mg dose for most of young patients.
Okay. I think somebody has some question.
Yeah, Lokesh, I have Dr. Mahesh.
Yes, sir.
Dr. Murli here.
Yeah, hi Murli.
So, leave the contraindications, leave the patient comfort. A patient says that leaves the decision to you. Like, I want the best treatment.
Yes.
Whether it is obinutuzumab plus BCL2 inhibitor or BTK inhibitors. Purely from a data point of view,
yes,
which is the best one, purely from a data point of view, if you want to incorporate BTK inhibitors? Yeah.
Yes, I would say obinutuzumab is best now.
Okay.
If the patient does not have any cardiac comorbidities, so what are the limited duration therapies you have? One, you have obinutuzumab. Two, you have venetoclax with acalabrutinib.
Amplify.
Three, you have venetoclax, acalabrutinib with obinutuzumab. In the upfront setting, there is not much data for the triple combination, that is acalabrutinib and obinutuzumab. Acalabrutinib, again monitoring and cardiac arrhythmias, cardiac disturbances, venetoclax would cause dyselectrolytemias, and acalabrutinib would cause cardiac arrhythmia. So this would be sometimes a deadly combination. You don't know when a patient would develop a prolonged QTc and would be subjected to tachyarrhythmias. So probably in my decision, like the best choice would be venetoclax with obinutuzumab for most of the fit eligible CLL patients, irrespective of the mutation status.
Okay. So, okay. And if you are using a antifungal like fluconazole, what would be your starting dose for venetoclax?
So for posaconazole, what we have been doing is we have been reducing the dose to almost like 1/4. We have done this for only AMLs, not for CLLs. For AMLs, our dose would be like 50 mg, 50 to 100 mg, venetoclax.
But the buildup starts from what, 10 to 20 mg? 10 mg,
For
20
AML,
mg,
we
and
don't
50?
build the dose. We start straight away from 50 to 100 mg because there the risk of tumor lysis syndrome is much less. However, for CLL, it is standard. You start with 20 mg and ramp up it over
50.
5 weeks.
Okay.
You think
So AML,
Jacobet
there is no dose titration. AMLs, you usually have to reduce the disease burden to a total white cell count of less than 15,000, either by using cytarabine or hydroxyurea, and then start with the standard dose of 50 to 100 mg of venetoclax along with posaconazole, because there most of the patients will require antifungal prophylaxis. However, for CLL patient, most of these patients are not on antifungal prophylaxis. Usually there is a ramp up period of 5 weeks for venetoclax. Starting from the second month onwards, you start it at 20 mg and slowly increase the dose over the 5-week period to 400 mg.
Okay. Thank you, Dr. Mahesh. It was excellent and good interaction. Thank you very much. Next, we'll move on to the next talk, sponsored by Novartis. It's a panel discussion by Dr. Murali Subramania, sir. Ask the STAMP experts. So over to you, sir.
Thanks, Lokesh. Let's allow me to share the slide. Okay. Yeah.
So Dr. Santoshi is there, Dr. Akila is there. Yeah.
Good evening.
Yes, sir, visible.
Am I audible? Slides are
Yes,
visible,
yes.
right? That's okay. Thank you. Thanks, Lokesh, for the opportunity. And thanks, Novartis, also for this opportunity. Good to see you, Lokesh. Now you're the head of the department. Congratulations.
Thank you, sir.
Congratulations. Okay. Right. So I've been given the task of a couple of case vignettes to understand the positioning of asciminib in frontline CML therapy as well as in the later lines. I'll present those cases as well as the two pivotal data which we have. One is in the frontline and then the subsequent line therapy. Okay, these are the standard disclaimers. This is the basic information regarding asciminib, actually available as 40 milligram tablet. The standard dosing is for 40 milligram twice daily or 80 milligram once daily for CML chronic phase. And the doses are much higher, 200 milligram twice daily for when there is a T315I mutations. So the first case is about a newly diagnosed CML patient, and then the follow-up case is about a treated case, treated with a couple of TK inhibitors, and then looking at further treatments. So this is a newly diagnosed CML, a 35-year-old young professional. She's found to have a low-risk so-called chronic phase CML. She's highly motivated to adhere to the treatment plan and is concerned about the potential side effects, both acute as well as long-term, and wants a treatment that could provide treatment-free remission. This is the idea profile, which is not a real patient. This is an illustration for discussion's sake. The patient has been given a name, Roja, young active. Dr. Santosh will go with you first. A low so-called chronic CML CP. What kind of drug characteristics you look at, and what? Now there are 4 or 5 frontline TKIs which are ATP competitive, and then we have a new first-in-class drug, asciminib. How do you choose the drug? What drug characteristics, safety, efficacy? What do you look at in the frontline therapy of such a young patient with CML? Yeah.
Thank
Dr.
you,
Santosh. Yeah. Yeah.
Generally, we continue to use like a second generation tyrosine kinase inhibitor like dasatinib when we start such young patients, keeping in mind the long-term safety data that is available and experience that we have with these agents, and also the TFR data that is available while using the second generation TKI and ability to stop the drug at some point in future.
Absolutely. A second generation TKI, Dr. Santosh, which was dasatinib. Dr. Akila, any other thoughts? Would you lean towards choosing a new best first-in-class drug like asciminib or a ATP competitive TKI? If so, what are the things which will make you choose that? Yeah.
I mean, there are no logistic issues. Considering the age of this patient, I would definitely would like to use asciminib, basically because trials have clearly shown that it gives better early molecular response, deeper molecular response, and major molecular response over the other TKIs. And since the age of the patient is less, I want to give a treatment-free survival for this. And once there is a deep molecular response, I think there is a safer withholding the drug.
Okay. So, is there any concerns that asciminib doesn't have still the long-term data for TFR? It has excellent data for EMR, MMR, and DMR, but the long-term data for TFR is still lacking. Does that concern you, or you're okay with using asciminib frontline here?
I think, like with the data available, I'm convinced that there will be a survival there. Giving rise, I mean, giving TFR.
Okay. Dr. Santosh, from the ASC4FIRST data, do you think, I mean, if at all, if there is inclination to start asciminib, I know your choice is dasatinib, do you have confidence to start this molecule with the goals of DMR and especially quality of life in this patient? Or you still want to wait? Are there any concerns you still want to wait? Yeah.
So I think the data for TFR will soon come out for asciminib. I think there is an ongoing trial looking at this question. The data is not out yet. So if the patient is very particular about quality of life and very minimal side effects, and looking forward to the upcoming data, which most likely will be a positive TFR data, I would not resist if the patient is very keen to start asciminib. However, as I mentioned previously, the go-to drug continues to remain a second-line tyrosine kinase inhibitor.
So, will you place this option on the table, Dr. Santosh? Yeah.
I mean, I would definitely mention the drug asciminib to the patient. Though till now I have not started not been able to give this in first line to any patient just purely because of cost concerns.
Absolutely, I completely agree with you. Yeah, I think we should offer this on table and see how the discussion goes. And Dr. Santosh rightly said that our experience with usage of dasatinib and then the long-term outcomes and TFR results are well known, and asciminib is not far away from that. So the treatment goals we all. Yeah, please, Dr. Akila. Yeah.
Sorry for interrupting, sir. I mean, I'm sure, like we really, when we use dasatinib, most of our patients really develop toxicity, at least thrombocytopenia. I mean,
I agree. We'll come to that. AEs are a major concern, and that's why this drug is going to be a go-to drug in the days to come. Novartis has come as with an excellent product. They have to place the cost. We will discuss about that. Excellent point taken, Dr. Akila. So we enumerated the treatment goals for this patient. We are looking at EMR, MMR, and DMR, and TFR is right. TFR is right on top of our goal, and a favorable tolerability profile. We want adherence. We don't want any the patient to not to adhere to the treatment, and of course, optimizing our long-term treatment outcome. So quickly, I'll run through some of the standard data which is available for DMR. For CML, we are well versed that MMR and MR4 and MR4.5 are very, very important landmarks in the treatment of CML by tyrosine kinase inhibitors. Here, there are three charts which are showing comparison of nilotinib with imatinib, dasatinib with imatinib, and as well as bosutinib and imatinib. It's clear that the second generation TKIs are superior to imatinib clearly from these charts. So treatments that increase EMR, I mean, the evaluation at 3 months becomes very, very important. And those patients who have less than 10% of BCR-ABL1 by RT-PCR, they tend to have a very good long-term outcome. We clearly see in this patients who are having BCR-ABL levels of less than 1%. The key 24 months, if you look at 24, 36, and 48 months, their outcomes for MR4 and 4.5 are very good. And this is the first step towards TFR. We need to achieve MR4 and 4.5 to even offer the patient for TFR. So normally, Dr. Santosh, how long you want the patient to be on an MR4, say, or an MR4.5 for you to be comfortable even to offer TFR? Yeah. Dr. Santosh.
Most of the patients we have done TFR is about 5 years. There are patients, a couple of patients we have done it based on some of the trials, and that even 3 years we have done patients not at all tolerating the drug very well, and they have achieved deep molecular responses. We have done it 3 years also.
Dr. Akila, what is your time frame from the time of MR4, let's say MR4 or 4.5 DMR?
I think I have also used 3 years, but I mean, though I've used it only for one patient, all my patients are continuously on medication. I mean, when I tell that, yeah.
Yeah, okay. So, yeah, this is an important thing. So, I mean, sustained response is what is very important. Do you, Dr. Santosh, do you look at the basic profile, baseline profile, like a SOCAL score or an ELT score to decide the TFR?
Sir, I go fully by the ELN guidelines, sir, for the last 2024 ELN guideline, which is specific points that we offer, based on which we offer TFRs.
So this is the point which Dr. Akila was clearly pointing out. Treatment-related AEs can lead to intolerance, and then they move from one TKI to another TKI. That results in reduced quality of life, treatment discontinuation, suboptimal dosing, non-adherence, and switching therapy. These all have impact on the final long-term disease outcome. There are enough data to show that if they don't adhere to the protocol, the long-term outcomes are much inferior as compared to those patients who adherence rate is more than 90%. I think what Dr. Akila was talking about is this cartoon. This cartoon clearly tells us the off-target effects. Dr. Akila, you were talking about dasatinib and the issues with dasatinib. So can you elucidate what are the concerns that you normally see in practice with dasatinib? Yeah.
I think initially, I mean, when we started with 100 milligram, but now I think with experience, we are just starting with 50 milligram, basically because the patients who were started on 100 milligram came back to us with thrombocytopenia, and which was quite difficult to manage.
Thrombocytopenia, even in CP, we find
Yes,
thrombocytopenia is difficult to manage. Okay,
yes,
okay. So I think it's
not difficult to manage. It's like we had to hold the drug for some time or the other.
Right. Okay. So this cartoon is very, very important. We should look at this multiple times. Here is the off-target effects. If you look at ponatinib, is all over, looking at tyrosine kinase, CMGC, CAMP, AGC, CK1. So it has off-target effects at multiple places, and that's how you see the adverse events with ponatinib. I think as you come towards dasatinib has specific off-target effects on SRC, and that's the reason you see the pleural effusions, fluid retentions. All these are kind of class effect of dasatinib. And imatinib also has off-target effects with mainly c-KIT, PDGFR, and you see muscle cramps, fluid retention, periorbital edema. These are all very typical. And bosutinib, with its SRC effect, typically has diarrhea as a standout adverse event. And in fact, if you look at all these ATP competitive TKIs, nilotinib is actually the one which has less off-target effect. And it has more specific inhibitor, but because it also has a bit of PDGFR and c-KIT off-target effects, it tends to have a lot of metabolic syndromes like hyperglycemia and other vascular events. So this cartoon kind of gives a clear indication as to regarding the off-target effects. Switching from one TKI to another TKI many times may not help. You are entering into a new domain of adverse event. Dr. Santosh, what is your comment on this off-target effects of these ATP competitive TKIs?
Absolutely, sir. All the drugs, maybe the imatinib is the best drug to use in terms of side effects. Other two drugs are up to 40% patients have pleural effusion with dasatinib, and ponatinib is something I use only if forced to use because of the vascular side effects that you are mentioning about. Yeah, definitely this is a problem for a lot of our patients.
Understood. Yeah. So we should remember this off-target effects with all these ATP. So there comes this savior drug, asciminib. It's the first and only approved BCR-ABL inhibitor that works by STAM, that is specifically targeting the ABL myristoyl pocket. The mechanism of action is depicted in this cartoon. Normally an inactive ABL1 binds to the N-terminus, has an N-terminus binding. The SS3 domain binds to the kinase domain at the myristoyl pocket. In CML, because of the VCR-ABL fusion, the N-terminus is lost, and then the inhibitory effect is lost from the myristoyl pocket. So what asciminib basically does is it targets this myristoyl pocket. You can see from the cartoon, the ATP binding site is entirely different from the myristoyl pocket here. Asciminib targets this myristoyl target. So all the resistances and then the off-target effects are what all you see with the competitive TKIs is not seen with the asciminib. So asciminib was tried in the frontline setting by the ASC4 first trial. As we are all aware, it's clearly one of the major landmark studies, the phase 3 study where the TKIs were investigator specific. That's the real world. I think they've chosen the comparator arm very good. Based on the investigator specific, the choice was given between imatinib, dasatinib, or any of the second generation TKIs. So clearly asciminib was superior to both imatinib or any of these second generation TKIs, which is shown from EMR at week 12 to week 48 evaluations, also clearly showing that asciminib was superior to any of the second generation TKI as well as the imatinib. So deep molecular responses at week 96 were also higher in asciminib across all the strata. And I think recently in the ASCO 2026, there was a presentation on week 144 update was there, and the benefit continued at the week 144 data also. So clearly the early results in terms of the EMR, MMR, and DMR are clearly superior to the imatinib and other existing second generation TKIs. So this is the most impressive chart as far as I'm concerned. I mean, for our CML patient, we should not do much harm. So many of the patients live long, live for decades, and there are comments that the CML patients have almost life expectancy equal to the normal population. Dr. Santosh, any comments on this AEs? I mean, from what you've heard of, I know most of us don't have any hands-on experience. Does this impress you? I mean, many of the side effects are mild hematological, and the grade 3, grade 4 side effects, off-target effects are not at all seen, Dr. Santosh.
Sir, I have fortunately I have few patients on asciminib, and even I have two patients with T315I mutation at 200 mg BD of asciminib, and it's remarkably well tolerated. When we look at the package insert with so many side effects, we are very careful in the beginning, including monitoring for lipase, amylase, looking at QTC intervals, etc., etc. But it's remarkably well tolerated with very good quality of life. And this chart is indeed a proof of that a good side effect profile.
Even this is at 200 BD, what you're talking about?
Yes, sir. We had right now two patients who are on 200 BD and doing remarkably well.
Excellent, excellent. So, I think it's one of the, with ponatinib having so many issues with 315, the toxicity issues, especially the vascular, and this acts by a different mechanism. So this becomes an obvious choice, but still you require a higher dose, 200 milligram BD. But it's heartening to know that even at doses 200 milligram per BD, it's quite well tolerated. So less discontinuations when compared to any other drug, first generation or second generation. Discontinuation rates are very less when compared to the second generation TKIs. So as for first week 96 analysis is quite encouraging. I mean, it continued to demonstrate that the MMR rates were high. There's always a treatment difference for MMR rates increased from 8.2 to 15 at week 96. DMR rates at week 96 remained higher with asciminib. I think it continued to remain high at week 144 also. So the early results are quite encouraging. I think we are just awaiting the TFR data. I think that will be the icing on the cake, and for us, it will be easier to choose this drug with the full data. I don't know how much time I'll have. I'll just quickly run through the second patient. This is another 45-year-old working
Another 5 minutes,
professional.
sir.
Another 5 minutes. I'll take this quickly. Yeah. So with a 6 months history of fatigue, general malaise. So this is a CML in a 45-year-old. This is a bone marrow biopsy, gross splenomegaly, significant leukocytosis, diagnosed with CML-CP with the BCR-ABL FISH showing 169 out of 200 cells were positive for BCR-ABL. Now, this patient, some treatment timelines are given here. This case is for the point which Dr. Akila was talking about, the side effects of the tyrosine kinase inhibitor. This patient was started on 400 milligram of imatinib, had a CHR at 2 months, did not achieve CCYR and MMR at 9 months, and switched over to change to dasatinib. The patient could not tolerate dasatinib, had headache, nausea, diarrhea, fatigue, and subsequently the patient could not achieve any of the milestones like CCYR and MMR because of the toxicity, and then probably not being adherent to the protocol. Dr. Akila, so this is a patient profile, 45-year-old, he was started on imatinib, did not achieve the milestones response, and then switched over to dasatinib. Even after switching to dasatinib, there were AEs, and as you rightly pointed, it did not achieve again the necessary targets. What do you think? What is the reasons for the treatment failure here? Does treatment cycling with second generation TKIs impact overall outcomes? Yeah.
Yes, I think basically the adherence is very important, and here, like again, like what I told, like the toxicity itself is a major concern for the continuation of the treatment, like pleural effusion and thrombocytopenia.
Yes.
Though we are able to continue with dose reductions.
Okay. So, Dr. Santosh, in practice, how do you plan the dosing of dasatinib in those patients who are exposed to imatinib? How do you start? You start with 100 and then scale down to 70 and 50. How do you do that here?
We start with 100 mg, sir, because there is data that 50 mg in Indian patients who are predominantly high risk in a large randomized trial led by Tata Memorial Hospital was inferior to 100 mg. However, even 50 mg and 20 mg patients are also there. We have seen in practice and seem to be doing all right. So that depends patient to patient and based on their side effect.
Do you think the pleural effusion kind of mellows down when you reduce the dose and they are
Yes, sir.
comfortable?
Yeah, yes, we have a few patients who had pleural effusion at 100 and doing well at 50. I have one patient who had even at 50 again recurrence of pleural effusion doing well at 20.
So that is also what I see. When you reduce the dose, pleural effusion kind of becomes easier to manage. Okay, Dr. Akila, have you in these kind of patients who are moving from one TKI to another TKI, as we understood that moving from one TKI to another TKI many times may not be the answer. You're looking at a different toxicity profile. Would asciminib be an interesting option in these kind of cases?
I think, let's see, basically the main toxicity of asciminib is going to be like fatigue and muscle weakness, which I think is I mean, I have 2-3 patients, just 2-3 patients on it. And these patients are comfortable rather than with the second generation TKIs, and I have not seen any major toxicity in these people.
Very good. Interesting. So this is some of the rate of treatment failures, which is with increasing number of treatments. So first line, if you use imatinib, then second line, a second generation TKI, and then subsequent TKI. With each shift what we make, there is response rates drops, and then eventually the ultimate failure rates could be 12% for imatinib. For a second generation TKI, it could be around 6%. So it's important to note that if using further third line second generation TKI may not lead the best results. Only a handful of patients will achieve MMR. Cycling through these ATP competitive TKIs may lead to outcomes that are not really optimal. Long-term response rates with third line, second generation TKI are not really sustained. It's important to note that more and more you expose the patient for TKI, you'll end up with some hazardous mutation like the T315, which becomes a very difficult proposition to treat. So needless to say, 315I has a very poor outcome, overall survival compared to the other regular kinase domain mutations. So this slide is important. It kind of gives an idea of the discontinuation rates with the various drugs. Dr. Santosh said that imatinib is kind of one of the well-tolerated drug. So it shows clearly in the slides the discontinuation rates at 5 years is 4%. The long-term discontinuation rates are 10%. We know that discontinuation rates are very high for dasatinib, or even for that case for nilotinib. Nilotinib has complex BD dosing and then relationship with food. All this makes very cumbersome for nilotinib, and then the discontinuation and adherence rates are very poor with this. So here, asciminib has the potential to address the unmet needs in patients who have had prior ATP competitive TKIs. It comes with a different mode of action binding to the myristoyl pocket and underlies the specificity of asciminib in this class of patients. So again, this was tested in a randomized fashion in the ASSEMBLE study against bosutinib. Bosutinib was the comparator drug with 2:1 randomization. This was found to be superior to bosutinib. These are all the profiles. Important to understand that when it was compared to AE, as I spoke before, diarrhea was one important side effect, class effect of bosutinib. Dr. Santosh, what's your experience on bosutinib? Here, see, you can see that is one of the significant nausea and diarrhea are kind of a significant toxicity with bosutinib, whereas this side effect is not much with asciminib. Dr. Santosh. Yeah.
Sir, I have zero experience with bosutinib. Because of the diarrhea as a side effect, I have not used it.
Yeah. Dr. Akila?
Same, even I have no patience on bosutinib.
Yeah, that is one of the adverse events which is really troublesome, which you can see in this forest plot. And diarrhea and nausea to the extreme left. This is very favorable for asciminib, and that is what these are the two side effects in the ASSEMBLE study, which what kind of standout. Other side effects are also mostly grade 1, grade 2, grade 3, grade 4 side effects with asciminib are very little. So this is another slide which shows that even in the third line setting, asciminib continues to improve the MMR data with each passing year. Such is the efficacy of this drug. So ASSEMBLE was the first randomized study, phase 3, using a second generation TK as a comparator for patients with CMLCB and previously treated more than 2 lines of TK. After almost 4 years of follow-up, asciminib continued to demonstrate superior efficacy. So even within 24 weeks, majority of them showed good responses in the form of MMR. So this is an excellent drug, even in this situation where prior exposure for 2 TKs are there. As we saw, the frontline data is also quite strong. Dr. Akila, Dr. Santosh, if there are any other comments, you can please comment. Else, over to Lokesh. Yeah.
Thank you, sir.
So we wind up, I mean, this practical question, aren't we really now using imatinib?
Yeah, I mean, most of the patients go on dasatinib in my practice. Very rarely, I mean, imatinib, yes, you're right. Imatinib usage has become very low.
Okay, sir. Then thank you, sir. Thank you very much. It was a very interactive session. I think you have covered most of the questions in relation to CML and the use of asciminib. Thank you. Thank you very much, sir. Thank you, Dr. Akila and Dr. Santosh, for as a panelist. We had a good introduction. Thank you very much. So we'll move on to the next talk, sponsored by Takeda, by Dr. Satish Shetty, is a senior medical oncologist in HCG Hospital, Bangalore. So we'll be talking on BRCAD HD21, the new benchmark in advanced Hodgkin's lymphoma. So over to Dr. Satish.
Thank you, Dr. Lokesh, for kind introduction. I request the organizer to share my slides. I'm not able to do it.
Kindly share the slides.
Yeah, visible. Can you enlarge it?
Can you put in a PowerPoint mode? Yeah.
Yeah, next 20 minutes, yes.
Yes. I'm going to talk about the what are the new benchmark in the management of advanced Hodgkin's lymphoma. This is my disclaimer. Next slide, please. See, I'm going to talk about the Hodgkin lymphoma 2-1 study, like how this BRCAD regimen has changed that management of advanced Hodgkin lymphoma. To coming to the Hodgkin lymphoma in India, that if we going for the epidemiology, majority of you will see that in advanced stage, and the presentation of age is have a bimodal age. Actually, the majority they try to present in the younger age, second and third decade, or maybe the elderly. Majority they try to show that the B symptoms 50% of patient, and the common type what we see in India is the Lixa cellularity, almost 60%. Next slide, please. Coming to the incidence, like you can see that bimodal age, even though if you see that the younger age and if you elderly people, you see that the older age patients they have inferior to the younger age because of the they're not able to complete the treatment of the thing. And if you come into the what are the options of treatment in the first line in the Hodgkin lymphoma is available, you can see here ABVD most of us we practice. Now this has become in advanced stage. If you see that may not be become many of us still we use it because of the cost constraint and other thing, and we have a various other regimens are there. That is escalated BRCA is young and fit patients. Sometimes we used to do it. Now other regimens are there. You can see here that brentuximab AVD regimen and a Nivo AVD regimen is there. Now the era of immuno-oncology, that Nivo AVD is people they try to use. The data is very impressive, but we have a very short-term follow-up of this 3-year follow-up. Brentuximab AVD is one of the other regimen is a 7-year follow-up is there, but only concern about the peripheral neuropathy. Accelerated because we have that, okay, even though 5-year data is there, but problem is the toxicity is a major concern. That's why that AB, even though ABUD is there, that is old regimen we to practice. Let us see that is there any change in the outcomes or nothing. Let us see that. Next slide, please. Next slide, please. Okay, if you come into the options, like because
Next
these are
slide.
the options. Next slide. Can you change the slide, please?
Backend team.
Hello.
Shagun, Shagun, can you share the screen again? Or should I share?
You can share and be active. Keep moving slides as and when.
So just a minute.
Yes. Okay. But we have this regimen is a Bricard regimen that is as for the neo data. But limitation of escalated pickup is there, even though efficacy is there, but we have a high toxicity. This is one of the major drawback of this regimen. Severe hematological toxicity, and like you can see the organ dysfunctions. You can see that along with the second malignancy you can see here, and a high chance of infertility is there. To have a best efficacy and maintaining that limited toxicity, we have that that is this hypothesis only. The modification of regimen has done with the Bricard regimen actually. Next slide, please. What is this Bricard regimen? Like this, I'm going to tell about. The next step, please. This is the component of brentuximab is there. The 3-weekly. Next step, please. Can you share? This regimen we have a like brentuximab that is 1.8. Like you have a brentuximab, etoposide is there that is 150 mg per minute day one, like day 1 to day 3. Cyclophosphamide is the same dose as like the accelerated pickup. Doxorubicin changes either, and the other regimen is 35 mg per minute. Here is a 40 mg per minute square. Dacarbazine, that is a 2 days, that is a day 2, day 3, and dexamethasone is a 4 days regimen is there. Is a 21-day cycle with the growth factor support. There's the modification of regimen, replacing the bleomycin with a targeted drug. That is one of the advantage, having highest efficacy and have a manageable toxicity compared to other regimens. Next step, please. Okay. See, this has been approved in the DCJs, this regimen, and even single agent also brentuximab has been approved. This regimen become the standard of practice recently approved. Next step, please. The committee, what are the guidelines, recommendations are there with the regimen? Next slide. We have both in ESMO and NCCN guidelines are there. You can see that ESMO 2025, you can see here that less than 65, 60 age is there. You can see the one advantage of the regimen is there. You can PET based, like you can see the modifications of the cycles. You can have a less number of less duration. You can complete the treatment. One advantage is there, and have a highest efficacy. After 2 cycle of Bricard regimen, you can assess actually with the PET-based interim PET actually is one of the decision factor. And if the W score is there up to 3, you can continue 2 more cycle, you can stop it. If the W score is a 4 to 5 is there, like you can you have to go up to 4 cycle of Bricard regimen, reassess. If the score, W score is coming less than 3, you can have a follow-up. If still persistent is there, you can give the radiation. These are the guidelines is there. Like is other like you have elderly people, you have because we want to have less cytotoxic, rheumatological toxicity, less side effect, you can have ABUD regimen is one of the choice. But one thing is you have to understand the brentuximab ABUD is one of the other options out there where neo ABUD is not available. You can use it. Where Bricard regimen is not able to suitable. This other alternative regimen also is available. Next step, please. This is NCCN guidelines. You can see here. This is also clear-cut guidelines as similar. First 2 cycle of the Bricard regimen. reassess intermittent PET based on the score. You'll titrate whether 2 cycle or 4 cycle, and you can do one of the option of follow and reassess after 3 months. And the negative can have the radiation is positive, either you can go for the refractory based treatment you can do. Next step, please. This is the like what we see that the newer options when neoAVD is one of the options, and now this Becker regimen is a category 1 recommendation is there. And based on the interim analysis you can do here, PET adapt based treatment, you can see that based on that, if the DeVilliers score is up to 4, is there you can do radiation, is 5 is there do biopsy, negative is there radiation, if positive is there you have to go treat as a refractory disease. Next step, please. Coming to this, we have a study that's like a Becker regimen, Hodgkin lymphoma 21-to-1 study design. Is the PET adapted based Becker regimen versus the older standard. Before this neoAVD, we have that accelerated Becker regimen was the standard of practice in the advanced classical Hodgkin lymphoma. Next step, please. That was one of the standard reference treatment. This is like next slide is published in Lancet journal. Next slide, please. You can see, look at this, like how the design of the study. We will have a 1:1 randomization of the patient in advanced Hodgkin lymphoma, 2 cycle of Becker regimen, 2 cycle 1:1 with the accelerated Becker. Do interim PET based on the positive negative. You can see that the negative is a 2 Becker regimen, the positive is a 4 cycle Becker regimen is there. Similarly, we will try to go for the accelerated Becker and restaging and PET based like radiation will be done. Next step, please. Coming to the results, next slide, please. You can see the beauty of this one. You can see that it's tried to have a better PFS compared to the older regimen. That is a 4-year 94%. Like that is better with a 5-year PFS is of 93.6% versus 90% with the accelerated Becker. This is one thing is going to show you the better efficacy compared to the older regimen. Next slide, please. Next slide. Okay, you can see that this is shown the decrease in the almost like 36% reduction in the PFS, say statistical significant decrease in the progression-free survival rate. That is very, very important actually, with this one showing that this become a new standard of regimen in the advanced Hodgkin lymphoma. Next step, please. Can see that PET scan is one thing guiding actually. With the PET scan, if you show that almost 2/3 of the patients, you can see PET is going to become a negative, like a second interim PET that you can see the 4 cycle of like you try to finish actually. That is the one thing. Survival rate is almost like almost equivalent to 97% at the 4-year versus the Becker regimen is less. But if you go for 1/3 of people, you can see that interim PET can be positive. They may go instead of total 4 cycle, go 6 cycle of Becker regimen. Still, that the survival rate is, you can see that 90.3%. It is better compared to the accelerated Becker. That is one advantage. 3 months you can able to finish up almost 2/3 of patient. You are able to complete the treatment in 3 months compared to the 1/3 of the patient. But the other regimens you try to finish extra months of treatment, longer duration with additional toxicity will be good. Next step, please. You can see here that is one thing, decrease relatively reduction of the morbidity almost like 17% when compared to the older regimen. Next step, please. You can see that like unprecedented efficacy you are seeing. Already 5-year data also you are seeing, and definitely decrease in the morbidity and tolerability definitely improve with this Becker regimen. This is a dual efficacy. Next slide, please. You can see here, coming to the OS data, we have seen the PFS data. That is the OS also. You can see that is numerically improvement in the Becker regimen, because it is favoring towards the Becker regimen compared to the accelerated Becker. Next slide, please. And you can see that 3 months completion with this treatment, 4 cycle. That's one of the advantages. Almost 2/3 of the majority of the patient you are able to complete, and a faster recovery of the patients will be there, quick recovery from the cancer-related fatigue, other thing, and that definitely the recovery from all the side effects. That is one of the advantage of this regimen. Next slide, please. Many patients ask that I want to finish up treatment. Coming to the safety results. See
Last
that,
2 minutes.
yeah, because they want to slides, they have to move fast. That's what is the only request. You can see that the hematological tox is definitely less. That is almost 20% reduction. Next slide, please. You can see here like decrease in the platelet and RBC transfusions will be there. Next slide, please. And I can see that here like a decrease in the neuropathy, even though like it is there, like you can see that older regimen having no neuropathy. That is one of the advantage because less number of cycles will be there, less neuropathy in this. Next step, please. And look at the febrile neutropenia also. Overall, it is like primarily like if you see in the first cycle and later subsequently less. You have to be careful. You have to monitor that. Next step, please. First cycle is the one thing you'll try to see that later you'll try to see. Anyway, febrile neutropenia prophylaxis will be used and later like GC support with that definitely decrease the side effects. Next slide, please. And I can see that the anthracycline exposure also less. You can see that total, even if you go 4 cycle, 160 mg per meter square. If you're going for 6 cycle, 1/3 of the patient will go for a 240 mg per meter square. Other, if you go whether ABVD, like all the thing, the Ventuximab, like Neo AVD, anything is there almost 300 mg per meter square. High anthracycline exposure. That is one of the advantage of this regimen. Next slide, please. And I can see that like a preservation of fertility is also important. Your shorter duration, you're the exposing and also like a recovery of the maximum recovery you can see in the fertility with this regimen. Next slide, please. And you can see this Bricard regimen is a the balance high efficacy and tolerability, lower anthracycline exposure, facility treatment completion within short span, that is 3 months. PET-guided approach definitely is very impressive with this novel treatment. Next slide, please. And coming to this, is there any data with the older age? Yes. Next slide, please. Is there above 60 years also? You can see that is a we have that data is there. Next slide, please. Because of shortest time and just on rushing over the slide, you can see that completion almost 82% remissions. You can see PFS data 2 years is 91% and OS data also 91%. Next slide, please. You see that data is also there in elderly people and even real world evidence also is there with from Israel. Next slide, please. You can see here like real world evidence also showing that PET like to see a CM complete metabolic response is almost 83%, overall response is almost 99%, CR 95%. You can see that this is the one thing advantage beauty of this drug with Israel that real world evidence. Like you can see only 4% of patients require a consolidation therapy. Toxicity is like almost consistent with the HD2 study. Low-grade neuropathy was observed here. Next slide, please. And the long-term efficacy of this data, like if you see that Bricard regimen 5 years data is there, but you don't have a data for the Neo AVD, that is one of the disadvantages. Let us see this. Next slide, please. You can see here, like this is one of the comparison. If you see that, yeah, younger age, you can use this drug, elderly, Neo AVD, even though you're preferring, but you can use even elderly fit patient also. You have to see that case to case basis, you can select and you can do. Across is going to work all the people, but patient fitness also should be seen at. Next slide, please, because of the long-term data. And summary, the Bricard regimen in advanced Hodgkin lymphoma, 5-year data is almost PFS is 93.6%, 78% of patient able to complete the 4 cycles, and higher rate of gonadal function recovery. That is one important in female and male also. Meaningful recovery time from the recovery, all those things there. It is one of the improved safety profile, good efficacy, better tolerability, PET adapted therapy, and fertility preserving. All the things are there. 3-weekly regimen you can finish in the short span. That is the advantage of this regimen. Next slide, please. I'll stop here. Like any questions that I'm happy to take.
Thank you, Dr. Satish, for excellent talk. Maybe how you will choose versus Neo AVD and Bricard. I think there is a topic of debate.
Yeah, okay. Yeah, that I think you can discuss in the panel discussions.
Okay.
Yeah. If you ask me that, yeah, like elderly unfit for the breaker regimen, I may use the NeoAVD, even though that the data is there like short, like it is a very short follow-up, 2 year data is a 2 to 3 years data. But this is the longest follow-up, almost about 4 or 5 year data. That's very interesting. That's the one thing. Only fit patient is able to take care. Thank you.
Yeah, fine. Thank you. Thank you very much. We'll move on to the next session, sponsored by Roche. It's a panel discussion by Dr. Vishwanath S., Senior Consultant Medical Oncologist from Apollo. So panel discussion is on the first line, management of DLBCL. Over to Dr. Vishwanath.
Thank you, Dr. Lokesh, for that introduction, and thanks for this opportunity. Can you please allow me to share the slides? Okay. Yeah.
Yeah, visible.
Yeah, thank you. So I think my panelists are Dr. Abhay Kumar, Dr. Rudresh, and Dr. Deepa, right, Dr. Lokesh?
Dr. Aparna.
Dr. Aparna, 4 of them. Okay. Yeah, so in the next 20 minutes, let's discuss this driving change in first-line DLBCL. I would like to thank Roche for this opportunity as well. So this is a disclaimer. So let's start with the first case. So we have a young patient, relatively young patient, 48-year-old male, who presented with abdominal pain, lower back pain, and weight loss for the last 3 months. And physical examination revealed palpable abdominal mass and flank tenderness. Lab investigations revealed elevated LDH. CT scan of the abdomen showed thickening of the stomach wall, multiple enlarged lymph nodes, and a mass in the right kidney. Upper GI scopy showed a large gastric mass. Biopsy showed DLBCL. Immunohistochemistry showed a non-GCP subtype, which was MYC and BCL2 positive, which indicates that it is a double expressor. The FISH was negative. Patient had a good performance status. Patient was staged as 4, and the IPI score was 3. So let me start with my good friend Dr. Abhay Kumar. So what are the clinical challenges in treating such patients?
So the basic clinical challenge is so DLBCL, the overall survival varies. It is very heterogeneous group. So based upon the GCB, ABC type and gene expression profile, the outcome varies. So some patients will do extremely well, some patients will do extremely bad. And especially the patients with high IPI, poor performance status. So all those things will not do well. So and hence, and all these patients, high risk patients, will not respond similar to the R-CHOP. So I think these are the challenges I feel.
Yeah. Yeah, I think Dr. Abhay Kumar nicely summarized it. It's not like one size fits all approach. We know that DLBCL is more of heterogeneous disease. And now we have the entire molecular landscape has also changed. It's not only the immunohistochemistry determining everything. We will come to that. And having said that, there are certain very limited disease also, which may just manifest double hit and they may do badly. And there may be certain patients who may do well. So it's a heterogeneous disease. Yeah, like Dr. Abhay mentioned, there's a great heterogeneity which exists in newly diagnosed patients with DLBCL, and the unfavorable outcomes are CHOP in higher IPI, non-GCP subtype, double expressor, high-grade B-cell lymphomas, double hit, triple hit. We have seen all that. We've had that very large manuscript which came in the British Journal of Hematology in I think 2015 from Yasuhiro Oki from MD Anderson, who clearly showed that double hit, triple hit require some kind of high intensity regimens, and it was clearly documented that dose adjusted EPOCH or even those high intensity regimens are better than R-CHOP in these patients. So we've also seen that progression-free survival based on the IPI is significantly different, and it stood the test of time over several years. And we know that IPI is a good way of determining the risk. And there is also significant data to say that the ABC subtype does badly as compared to the GCB subtype. But having said that, now there is so much of molecular heterogeneity, and we will come to that. And the overall survival also is significantly lower in patients who got double expressor, that is on immunohistochemistry, as compared to those who do not have a double expressor phenotype. So, Dr. Aparna, how important is the IPI score in prognostic stratification, informed treatment approach, and patient counseling?
Yes, I think it's a very important tool, and sensitizing the patient. What happens when we encounter lymphoma is that we get all enthusiastic that oh, it is curable, DLBCL will respond well, and sometimes they actually respond very well, but they tend to relapse within an year or two, and patients feel a little disheartened. So it's very important that in the upfront, in the first line setting, it's better to check the IPI score and tell them that it's actually a high risk candidate, and whatever we do, that okay, even if they get a very good response in the short term, there is always a risk of recurrence. And I think patient counseling makes it more easy for the family to handle this kind of difficult situation.
Yeah. Yeah, I think all of us would agree that what Dr. Aparna has told. And of course, the treatment landscape has also changed, and we tailor the treatment accordingly. We'll come to that. So there is definitely a major unmet need. Dr. Rudresh, do you agree that there is a major unmet need in these patients who have got a high IPI? Dr. Rudresh?
Yeah, most of the patient with high IPI score will be doing badly. It is having the prognostic value. So in them, though initial response may be there, most of them will get relapsed. So in them, rather than R-CHOP, we should intensify with other mode of treatment.
Okay, perfect. This is where the POLARIX trial, Dr. Deepa.
Yes, sir.
So what do you think about this POLARIX subgroup, and where it is clearly shown that by adding polatuzumab and replacing polatuzumab for vincristine, and you're seeing that in the subgroup analysis, patients who've got a high IPI, they do better. The hazard ratios are better as compared to those who've got a lower IPI score.
Yes, sir. So the patient with a high IPI score, we cannot simply prognosticate on the basis of the high IPI alone. So we should have the knowledge of the molecular profile of the disease, because even the patient with a low IPI, they may have the high risk molecular profile, like they may have MYC or BCL2 expression. So based on this IPI alone, we cannot prognosticate the disease. And based on this POLARIX trial, we have the trial has shown that the patient with a higher IPI, with 3 to 5 IPI score, they have done better than those with the less IPI score. Now we can see the hazard ratio of 0.72 in the high IPI score and 0.91 in the lower IPI, intermediate IPI score, like 2. So the patients with the intermediate to high IPI score, we should opt for the POLA RCHP.
Yeah, I totally agree with Dr. Deepa. I'm sure the other panelists also agree that it should not be taken in isolation. Molecular phenotype, and now we have the NGS, so many things coming up in DLBCL, that we have to take everything into consideration before deciding the regimen. But yes, patients who had a high IPI did better as compared to patients who have got a lower IPI, especially with the POLARIX study regimen. So let me go back to Dr. Abhay Kumar. What is your opinion on prognostic significance and treatment implications of molecular subtyping?
Yeah, so earlier we used to treat all DLBCL similarly, but now we are dividing them into GCB versus non-GCB. And there are many multiple studies. Though in general, GCB will do good prognosis, non-GCB will not do.
So to improve the outcome in non-GCP, there are multiple ways they tried adding a ibrutinib, bortezomib, lenalidomide to the CHOP. So it did not change much difference. So basically, the recent trial, that is POLARIX trial, adding a polatuzumab has only shown the benefit in terms of EFS and PFS. Otherwise, previous other trials intensification, so did not show any change in the overall outcome.
Yeah. So this has been there for quite some time. We just know that phase 2 trial from Dr. Robert Novakovsky from Mayo Clinic, which actually showed that R-square CHOP was showing some benefit in especially the non-GCB patients as compared to GCB. But overall, like Dr. Abe mentioned, most of these regimens have been a failure as to decide which, based on the molecular phenotype. And it is this particular regimen, the POLARIX study has shown some promise, especially in the non-GCB subtype. So going back to Dr. Aparna, a lot of things have changed in DLBCL from the time probably we did DM, and now it is not only about GCB, ABC, and by molecular or the IHC, GCB, non-GCB. There's so many things coming up. In fact, the NGS, the LymphGen, and then the clusters, and then the dark zone signature, which basically indicates something like a double hit, but the molecular analogy or analogous of the double hit on fish. So many things have changed. What are your thoughts? And of course, we are not using any of these. Are you using any of these in your practice?
I actually tried NGS for some of my patients who were non-GCB. So I really like this dark zone signatures. So the dark zone of the germinal center, and I was actually in the dark zone, not knowing about these newer advancements. So I think it's a learning curve, and because this non-GCB is a very tough disease, and the all these new markers are actually welcome, and it's not only the fancy mutations or the translocations, but our own labs, are they equipped enough to detect these tests? And what about the material? Sometimes we just do a true cut biopsy. If it, like the stomach, you had shown the initial case. Most of the stomach cases, we just do an endoscopic biopsy and we get a diagnosis. We don't have the entire lymph node also sometimes. So getting the right kind of tissue and getting these tests and interpreting them, I think it's a big challenge, and we are still taking baby steps to understand.
Sure. Yes, Dr. Aparna. So my question to the other panelists, very similar question. Are any of you doing NGS? Let's make the answers also short so we can have more discussion. Dr. Abe, Dr. Deepa, and Dr. Rudresh.
I am not doing.
Dr. Deepa? Okay. And Dr. Rudresh?
No. We are not doing only IHC and
I think
infrequent,
most of us are not doing, but like Dr. Aparna said, there are various factors which also have to
My
be kept into
mother-in-law
consideration.
was diagnosed with DLBCL, so that's when I did only for my mother-in-law, not for everyone.
Yeah. So which lab did you send it to, Dr. Aparna?
We sent it to this Strand, sir.
Strand.
Strand.
Okay. Yeah. So Dr. Rudresh, so we do know from this the IHC that we do know from this particular study that the concordance of IHC versus gene expression profiling is not great. So what are your thoughts? And we may end up missing a lot of patients.
Yeah, I think almost 20 to 30% of the patient where IHC may be showing good prognosis in the IHC, but if you do either PCR or NGS, we may get higher risk where intensification or giving polatuzumab based chemotherapy may be beneficial.
Yeah.
There is a discordance.
Yeah. So I think definitely we are just restricting ourselves to IHC, so we may be missing out. And we may be missing out on situations where we actually think as it is a GCB and we may not want to give POLARIX regimen. But in fact, these patients may actually benefit because their dictum is that in POLARIX, the GCB patients did not have a great hazard ratio. But this point has to be kept into consideration before we make a decision. So if you see the PFS by cell of origin, Dr. Deepa, again,
Yes, sir.
see, if you see, this is what I was alluding to, that in GCB, if you see the hazard ratios is not great, and you can see that the curves are merging. But if you see the ABC, there's a significant difference, and the hazard ratio is fantastic. It is 0.34. What are your thoughts?
So this ABC variety, because of this the signaling of BCL oriented signaling, there is a target of CD79B. So the targeted therapy of polatuzumab on CD79B must have have impact on the better outcome in the ABC variety.
Yeah, perfect. Dr. Abe, there are quite a few molecular markers, and now if you do that lymph gen, or you can look at the clusters, see if there's, like Dr. Aparna said, the dark zone signature, GCB signatures. So all these things are very very interesting, and based on this also we can tailor therapy. It's like, for example, the cluster 5 patients did well, that patients who had a dark zone signature positivity did well, and if the patients had that EZB MYC positivity or the MCD, they did well with POLARIX. So if you see this graph, this particular table, look at the hazards. So even if you have a GCB, for example, Dr. Abe, and you have an EZB which is positive, and you see the hazard ratio. But overall GCB, if you see, the hazard ratio is 1.03. And if you have this, so what are your thoughts?
I think so it's all based upon the exploratory analysis. So retrospective exploratory analysis, it's basically not made for that. So, but and also the power of the study is not meant for that. So that's why it is very difficult to interpret this based upon the only these gene signatures. But in general, we can say that GCB is not going to do well. ABC will do well. So in that GCB, they looked at EZB, which they are doing well. So, but I will not go by just by exploratory analysis. We have to be very cautious when we interpret the exploratory analysis.
Okay. So in your practice, of course, in our practice, currently we are not doing, but these kind of data definitely, and these hazards which are in the exploratory analysis, which are quite meaningful, does indicate that we should also probably do these molecular analysis. So again, this is just to show that patients with cluster 5 did really well. Again, if you see the hazard ratios were better, just goes to say that molecular testing is also equally is important. So just to summarize, that patients with ABC did better, molecular profiling is important, lymph gen classification, some like EZB, MCD, these patients had favorable outcomes with POLA RCHP. So let me go back to Dr. Aparna. How do specific extranodal sites influence your treatment decision?
Specific extranodal sites, I'm not actually doing anything extra. Extranodal site itself is a poor prognostic marker, but in this case, I was a little worried about the renal mass. And when there is a high tumor burden, there is a risk of tumor lysis syndrome, so that we have to give some prophylactic rasburicase and go ahead. But otherwise, specific extranodal sites, I'm not changing the treatment, sir.
Okay, fine, fair enough. So anyways, this patient, we do know that 2 or more extranodal sites does indicate poor survival. And this is a distribution of molecular subtypes according to the biopsy sites in a Japanese retrospective study. If you see the ABC, DLBCL, it's more common in the breast and testes. GCB is more common in upper GI or lower GI and thyroid gland. And the dark zone signature positivity tumors not significantly enriched in any specific extranodal sites. This is an interesting point, which I think most of us have to know.
Last 2 minutes.
Pardon me?
Last 2 minutes.
Yes, sir. So I'll summarize very quickly. So POLARIX patients with DLBCL and extranodal disease demonstrated superior PFS. Just goes to say that patients with extranodal disease, again, you can consider this particular regimen. Last few points. So I want Dr. Rudresh, if you look at this forest plot, the various situations where, especially based on the extranodal sites, that you can tailor therapy, whether you should give POLARIX regimen. Do you think this would be something you would do in a Monday morning clinic when you go back after today's panel discussion?
No, depending on the extranodal site, I may not change. But any extranodal site, as you told, more than 2 will be having the poor prognostic factor. In them, polatuzumab is beneficial. And I will be keeping in mind where are the extranodal site. For example, if it is from the testes or if from the breast or if from the renal, so those patients may require the CNS prophylaxis also.
Okay.
Otherwise, depending on the site, I may not plan all extranodal site more than 2 is
Yeah, I think we can all look into this particular forest plot later, but there are certain sites which do better. So again, clinically high-risk patients and so Dr. Abhay Kumar, I would like to ask you this question. If we see the 5-year update, right, mainly PFS benefit is there, but if you see the ABC subtype, there is OS benefit also. But just a PFS benefit in first-line DLBCL, quick answer, is it enough? Yes or no?
Yeah, it depends because obviously the OS is the gold standard, but it is very difficult to prove in DLBCL because 60 to 70% are cured with R-CHOP, only rest 30%, and there will be a crossover. They will use second line CAR T cell, antibody drug conjugates, bispecifics, and autologous. So that's why it is difficult to prove the OS. So it's our goal is that if we prevent any second line exposure to second line therapy, that is also important endpoint because they are associated with a lot of morbidities and mortality.
So like Dr. Abhay said, but in this particular POLARIX regimen, if the patients were used in the first line, fewer number of patients were actually exposed to CAR T or second line regimens. But if you see the overall survival, this is the intent to treat population, it was not significant. But if you go back and look at the 2025 data, the update in ABC subtype, there is benefit. And Asian data, again, Asian patients do well. The hazard ratio is 0.65, which is again very meaningful for our country patients. And one point I would like to summarize before we close, that the side effects over a period of time, it was not too bad. And even with the extended follow-up, this is something. And I would like to also say that in patients with double hit lymphomas, where it becomes very challenging, like Dr. Aparna also mentioned, that dark zone lymphoma by molecular. Apart from the other high-risk regimens, you can also use Pola RCHP because if you see the double hit lymphoma patients, though the numbers were not huge, there was benefit. And with this we covered. And I think the most important thing is about older patients. One last point from each of you before we close this entire panel discussion. I think most of the topics we have covered. Let me start with Dr. Deepa. Quick point. Will you use in elderly patients? Because if you see the POLARIX data, there was benefit in elderly patients.
Yeah, so even the patient is having advanced age, the toxicity profile, the safety profile is similar between the young patient and the elderly patient. So if the patient is having the high IPI elderly, yeah, we can go for the Polar RCHP.
Abhay, what about you? Yes or no?
Polar R mini CHP.
Okay. What about Aparna?
Actually, R-CHOP itself is very toxic for elderly patients. So when we are using POLARIX protocol, extreme like prophylaxis is required, and the toxicity can be really problematic. So with caution, we can give POLARIX, or otherwise, as Dr. Abhay said, we have to cut down on the doxorubicin and make it more like a Pola mini R-CHOP kind of thing.
Dr. Rudresh? Quick point from you before we close it.
Any old patient, I will start with the preface. Then I will start first 1 or 2 cycles. I may avoid adriamycin, and definitely I will add polatuzumab. If they tolerate, then I will reduce the dose of adriamycin in subsequent cycle, and of course other prophylaxis.
I think I've also had a very good experience in elderly patients. They've done well with this POLARIX regimen, but we'll have to again tailor the regimen, reduce the dose according to the patient, and make it very individualized based on the patient's general condition and various other factors.
Yeah, and I would like to add that my mother-in-law got CMR after 3 cycles and completed all the 6 cycles.
Yeah,
Polarix,
that's fantastic to hear, and thank you, Dr. Aparna, for also sharing the clinical experience. And I would like to conclude by saying that this Polarix regimen is a very good regimen, and especially for patients with high risk and those who have got ABC subtype, and like Dr. Aparna said, dark zone signatures. So that also indicates double hit lymphomas by FISH, and all these, and elderly patients. These are the groups of patients where you definitely use this Polarix regimen, and we have all had good real world experience. We can all share where we've had great experience with this particular regimen, and patients are inching towards cure, and we can probably avoid these CAR T, autologous. Lesser number of patients go for those novel therapies, which probably can be kept for the future or even not required at all. Thank you, Dr. Lokesh, and thank you, my panelists.
Vishwanath, I have a question.
I think we're running short of time. You can ask Dr.
Yeah,
Lokesh.
maybe you can ask one question.
Yeah.
Yeah, so Polar in this trial, they use 6 cycles R-CHOP versus Polar CHB. And again, 2 rituximab there, which is not a earlier standard practice. So are you practicing that one?
No. In fact, I have discussed with the investigators also. Nobody is giving this 2 rituximab single agent. I was also a little surprised when I had initially planned this Polarix regimen. And then I asked, recently we had one of the Polarix investigators who had come to Bangalore, and I asked this question specifically. Nobody's using this.
Thank you.
Thank you. Thank you, Dr.
Thank you,
Lokesh. Thanks
Vishwanath,
to all the
for that
panelists.
excellent, very interactive session. Thank you very much. Thank you all the panelists for very good discussion. Now, next move on to the last session. It may be more interesting for all of us, from experience to algorithms, how AI can adapt to oncology, by Dr. Shahir. Is a pulmonologist. So over to Dr. Shahir for the further talk.
Sure, Dr. Lokesh, I'll be sharing my screen and getting started right away. Can you confirm if you can see my screen?
Yes.
Okay, great. Thank you. Yep. So let me begin the session today with just a bit of locus on why I'm speaking on this topic. So as a fellow doctor, I completed my DM in pulmonary medicine in 2021, and for the last 5 years, I've been doing this full time, developing AI algorithms for clinical use. So far, I had success with 3 FDA-approved algorithms. This is being deployed in the Mayo Clinic and Duke University. About 6 patents and 430 citations. I'm talking about all these because this has all been possible because of one change that I did during my DM residency. That was I started learning Python. With Python, and then later came AI, right? I was able to do these many things, with relative ease. I felt like, it was extremely easy to churn out data analysis that would generally take a lot of time with SPSS and these things. And since it was long before the ChatGPT came into the picture, so a bit of early mover there. But I'll also tell you why, as oncologist, you need to, be on this page really, because this is no ordinary person. This guy, because I'm working with the computer science people now, so this guy is very famous in this because they store all the code in this person's lab. So he's not an oncologist. He had stage 4 spinal osteosarcoma, which returned after surgery, radiation, chemo. He was told to accept his fate because that's the end of the thing. So this guy, what he did was he took all the samples, biopsies, and took all the profiling of that and turned it into like 25 terabytes of data, and then used ChatGPT and got a geneticist to assist him. And they got about 19 personalized vaccine candidates. And this person is in remission from 2025, is a very famous person. And he's uploaded all the data at this side. So why I'm telling you this is the direction in which AI is going, and more and more you're going to face these things. Patients will be taking a lot of help off the shelf from AI, and I can only imagine what would happen if the oncologists are all using AI in their or develop AI really, because nobody knows where in cancer therapy or cancer knowledge does AI fit in, which you know best. So I strongly encourage you to get on this board. Now, just a bit of demystifying how AI is there so that you don't get too overwhelmed with what really is this thing, right? So I have just selected two images. Obviously, they have very different morphology. So you are probably more experienced in identifying these things. You can see an adeno here and a squamous cell carcinoma here. And it is pretty obvious, right? Like if you teach somebody, some medical student or a resident about these things, it is pretty easy to remember why this is adeno and why this is squamous. They look different, and that's what the training that we do to humans. Okay, now let's invert the thing. Okay, now instead of training a human, I train a machine. Okay, I give it like 100 slides of adenocarcinoma. I give it 100 slides of squamous cell carcinoma. If humans can learn these things and tell that this is this and this is this, how difficult is it for the machine to do that, right? In fact, it does it really well. And I'm going to show you some examples of what people have achieved doing this, and you can see you can train models like this. Basically, you just need labeled data, and that's a thing. Now, it is a pretty easy one for so experienced, oncologists. So this is meant more for maybe the lesser well-versed in oncology, maybe 58-year-old with 6-week history of persistent dry cough, not settled despite antibiotics, loss of weight, all telltale signs, right? Increased fatigue, reduce. Like there cannot be a more, obvious case of this, right? But just with the presenting history alone, right? There is a very good chance you can actually predict whether this is benign or malignant, right? I'll just hold here for you to think for a moment. There are some patterns that you are seeing in this history that are like very suggestive of malignant etiology, right? But it may so happen that this patient could indeed be benign, right? There is always a possibility. So there's only so much you can do with history alone, right? But still, looking at this, you have a hunch that this is going to be malignant, right? That hunch is the pattern that you have seen over time. Like you've studied about this in the books. You've seen patients come like this, With all this, you have developed that hunch, that pattern in your mind that this could be malignant, right? So now, this is exactly what AI also does, okay? It does not do anything, right? It has just learned through going over thousands and thousands of, patients just like you, and, decades of training. There are so many cases. Doctors have described cancer so well in the literature. They have written papers, posters, everything. So it is learning from all this and then doing the same thing that one is doing, that is trying to find a pattern in that history and then fit that pattern to something what it knows. So in that thing, the pattern may fit a more malignant case, and that's exactly what humans have been doing. Okay, so it's the same thing. Like our teachers have taught us along the same lines. They have transferred their years of experience to us, and the patients have taught us by presenting with the disease. And over time, we have also learned that thing. So now AI is doing the same thing. It is just trying to get the hunch, get the pattern, right? Now, there's another question here, right? 67-year-old man, months of worsening urinary hesitancy and nocturia, new dull lower back pain, irregular hard prostate, and some unintentional weight loss, right? So his PSA is being measured now. The decision cutoff is 4, right? So again, your call now, right? What is the possibility that this patient's PSA could be over 4? or what possibility that it could be below 4? So if we go by, whatever we see in the usual thing, I have a hunch that you might actually say it could be above 4, right? Or I may be wrong, and you could actually say that these things don't fit into this thing. It could be below 4, right? It could be any of those things. Why I'm showing you here is this is what exactly AI also does, right? It takes into account these things and comes with this decision. Now, how did we come to this decision? Suppose the answer is above 4, right? We came to this decision because, again, we have read books, we have been taught by teachers, we have seen patients, we have found all these patterns like lower back pain, irregular heart prostate, and weight loss, and all these things. And we think that it could be related to prostate, it could be related to an increased PSA. And that is the pattern that we have learned. Now, if I give the same pattern to AI, okay. Now, since I do work with large EHRs in the US, so they have like millions of patients' data, right? We may not have that many. We have more patients than the Western Hemisphere, but definitely the number of data points that they have as collected, because they've been doing it for decades. They have a lot of this data. Now, if I point AI to this data, and I catch hold of all the patients, and give these predictors like age, smoker, cough, weight loss, hemoptysis, and then I also have their biopsy result with me. Now I say this was malignant, this is not malignant, malignant, not malignant, malignant, no, not malignant, and so on, right? Now, if I train an AI on this data, and then I show this patient to it, right? This time I won't tell the diagnosis, okay? I have trained it on, say, 100,000 patients with these data points. Then if I ask AI, a new patient has come, 58-year-old, is an ex-smoker, cough, yes, weight loss, yes, hemoptysis, yes. How difficult it is for AI to tell that this is malignant, right? So that's exactly how we have learned. That is exactly how AI is learned, which is why the common thing between natural intelligence and artificial intelligence is the word intelligence, because intelligence is the thing that is common. We have a natural one, and we have just managed to transfer some part of the natural intelligence into the machines, and that's what we are calling as machine learning. So by now it must be obvious to you that if there is no data, there is no AI, right? Data is the most important, because as you're seeing here, right, without training AI on these, we can't expect it to answer this question, right? Same way, without training a resident on all this, right, you cannot expect the resident to know what would happen if this patient is seen. So it's the same thing actually. So just like the only difference is the AI does not sleep. It works continuously. It can read through millions of data points, while humans have some limitations, but humans also have something extra, the natural intelligence that AI has not yet been able to like completely, come to terms with. But the philosophy is the same: no data, no AI. So data is very important, and anything that you want to train or do with AI, you need to first get hold of data, and that's the first and foremost thing, right? Now, just giving you a further example so that it becomes very easy for you to understand what AI is going to be. We'll see. So like the way I was taught, X-rays was just going through these, normal pneumonia, pneumothorax, and all this. And in the exam, we are asked, what does this, what does this X-ray have, right? Do you identify what are the things? So during training, right, we are taught everything about this, right? Why this is pneumothorax, why this is effusion, why this is pneumonia, why this is normal. All these things we are taught. And during exams, we are asked this question without telling the answer. Obviously, they want to test us, right? So AI is the same thing, okay? So what do we do? Say you have 1,000 patients' data from Kidwai Hospital, and you have, the labeled outcome also. So you have done biopsies on those patients. You have outcomes, whether it was malignant or benign. I'm just taking a very simple example. What you do is you don't give 100% of the data to AI. What you do is you give 80% of the data to AI. So on this data, it will learn. It will know which is a malignant case, which is a benign case, and what are the things that, the cough, weight loss, and all that thing we will give, right? For it to learn from the features. But in exam, right, this test set is basically your exam. In exam, we don't give the outcome, whether it was malignant or benign. We just give it, this patient had cough, weight loss, whether this patient was ex-smoker, current smoker, age, and all these things. That's it. And then we ask the AI to predict on this thing. And then whatever it predicts, right, that is what we score this model on, right? So that is the foundation of AI, right? Training set and test set are separate. For training, we give it all the labels outcome, but for test set, we don't. Okay. And then we have two kinds of AI, right? You might be reading it in your journals and all. One would be classification, one would be regression. This is nothing. Classification means if your outcome is binary, say malignant and benign, then that's your classification kind of AI. If it is, continuous values, like, you're predicting the prostate specific antigen levels or tumor size or months of survival or risk, that's when your regression algorithms comes into play. So if it is binary, you would know by now that, it would be sensitivity and specificity. That is the main thing. And if it is continuous, you will have some of these mean absolute error. Basically, what it means is if the algorithm says PSA level is 5, but the patient's actual PSA level was 4, then the difference is 1. That is the mean absolute error. So error is 1. In another patient, error could be 2. Another patient, error could be 1.5. If you take a mean of that error, that's what you get, mean absolute error, right? So at the heart of it, these are very simple, and you should learn more on this. I'll be just giving an outlook of what it is so that you can pick it up. You have the data and you have the credibility, and you must definitely try these things. So what can be the predictors, right? So generally predictors are those things which beforehand, right? When the patient walks into your clinic, you want to know whether this patient might have something, right? Whatever you are predicting, right? Whether you have that or, but you don't want to do the final biopsy and all before, right? So you want to know which patients to take up for biopsy, which patients to take up for a PET CT or stuff like that. So you should use some of those details and try to predict the outcome, but you will have to train the data. So you will have to have a training set, test set, or labeled outcome should be there for both of them. You train on this, you test on this, and that's the way it works. And we have seen the metrics. Now some examples, a couple of slides, and then we are done. So these examples are like, what are the things that are already being done in oncology? Like one very famous thing is your mammogram images. Basically, they have trained an algorithm. They have done the, FNAs, and, they know which mammogram image has what malignancy or benign in that way. They've trained the algorithm. Now they are just using it. And another algorithm is for, the patients with lung cancer risk. It predicts. So they have the data of their CT scan and how many develop lung cancer. Now they just trained on it, and new CT comes, it will just tell you what is the risk. The skin, you are already aware, like, how they do it. And then metastasis detection in lymph node. So they have trained they have shown the histopathology to AI and the diagnosis the pathologist gives. They're given tens of thousands of slides. Now, one new slide comes, it will automatically tell you whether it has metastasis or not. Same for prostate, same for molecular status. And then colorectal cancer, specific survival risk, again, those things. And in colonoscopy, like during live video, they'll detect adenoma, right? And this they are doing how? Because they have given the AI the videos, and they have also told adenoma how many of them actually had. So now, after training on many videos with known data, now any unknown data comes, any new live colonoscopy video comes, it will detect this. So stuff like this is there. So also wanted to introduce you to one, so the AI is coming from all directions towards medicine, and it is an irresistible force. This is the last slide. So this is one other tool, which I had developed to make a virtual doctor. So if you just give the, the history, exam findings, or just take a pic of the biopsy report or something, it behaves exactly like a doctor that is well versed in all the society guidelines, and takes you through how to do the differentials, how to do the investigations, all based on Bayesian statistics, which is the core of AI. So we have developed this this way. So you could also use some tools like these, or you could make your own tools, right? It's become very easy now. It does not need a expert computer science guy to do any of these. These are things you can do by yourself. And it's pretty so easy that you can do it in like 4 to 5 hours, what used to take many weeks before. But in general, right, the whole thing is they are saying that AI is going to get natural intelligence soon, right? They call it advanced general intelligence, AGI. And they are saying that if the AI algorithm, if you just restrict the training to before 1911, and then if it discovers the law of relativity, right, what Einstein did, then they will consider that this AI has got a natural intelligence, like human beings, it has become, right? That is a benchmark they've set, right? But as a doctor, it felt very, awkward to me, right? Because what I feel is the real proof of natural intelligence in artificial intelligence will be when the AI can actually make cancer into something like how antibiotics have made it for typhoid and tuberculosis, right? That is the power of AI. This century, with AI, if cancers are not solved, then we can say that the AGI has probably not come. That is my belief, given the power that I have seen with AI in the last 5 years. So I'm extremely confident that medicine is going into uncharted territories. That's the same thing that the GitLab owner had done with himself. He had discovered new cure for himself, exactly for himself, just tailor made for him. So same things are going to happen with oncology. Hopefully we'll solve this scourge of humanity in this century with AI. And I really hope you are the ones who are leading this. And if you need to know more resources on learning AI, or trying out this app or anything else, you can write to me, or you can reach out to me. And I'm very happy that you have shown interest in actually having a talk on this subject, and be eager to learn about this. I take it as a very positive sign. I'm very thankful to Dr. Lokesh for giving me this opportunity. Thank you, sir.
Thank you so much, sir, for the insightful talk. Let me invite our program convener, Dr. Lokesh KM, Professor and HOD, Department of Medical Oncology, Kidwai Memorial Institute of Oncology, Bangalore. Sir, over to you for closing remarks.
So thank you all. Thank you, Dr. Shahir. It was a wonderful talk. I think I will get back to you regarding more and more information regarding the same as we are short of time. So I'll maybe contact you again for the same. Thank you, all the speakers, moderators, and panelists, all the attendees, audience. Thank you very much. It was a very good interactive 2 days. Maybe last but not the least, I would like to thank all the sponsors for their continuous support in helping us to do all these meetings and make it more successful. Thank you very much. Thank you, the technical team. Thank you very much for all your support. Thank you very much. Good night to all.